1:15. Thank you all very much for being here. For those who looked at the agenda, you will see we have a fairly lengthy agenda today with several major items for our discussion. So again, I appreciate each and every one being here. Normally we would have our chaplain at this time, and Robert, I think you'd like to make a few comments that you and I discussed.
Many of you know that JPS becomes family, and it's very, very difficult for us to lose a family member. We lost Dan Baker, and the family appreciated the fact that we did not have discussion during that time that he had struggled through some of the issues that he was facing. Dan passed away, and he was such an instrumental part of JPS. And he was able to rally people at their lowest times and provided such support to us and to our patients. And we will miss Dan Baker. So I asked the chair, and the chair is going to take over here, but I know that there were 2 memorial services for Dan, one in the community and one that we had here at JPS. And I had the luxury, as well as the chair had, to be with Dan in some of his more challenging health times. And I have never, and I don't know that I ever will, witness anybody who accepted his fate so bravely and so securely. And Dan Baker was an incredible man. I think the mistake we would make, we should be sad. Obviously, we're not going to physically see him, but if we don't carry on Dan and the tradition that he had, the humor that he had a sense of talking to spiritual sides better than any of us, and he could laugh and he could joke, and he did that well, and we appreciated that. So we owe, I think, Dan and the legacy that smile that Dan always brought to the beginnings of these meetings and many of our other meetings. So, Mr. Chair, if you wouldn't mind taking over from here, but we will miss him, and we're appreciative that we had known him.
Robert, I appreciate your comments, and I, like so many, had the pleasure of knowing Dan over the last, in my case, probably the last 6 years. At the memorial service, this room was packed. I think Reverend Emerson made a comment there, talking about the man, how he's walked these halls for 22 years, provided comfort to our patients and our staff and our employees. So we thought today that we're going to ask for a moment of silence instead of having a prayer. And after that moment of silence, in Dan's honor, would you then please join me in the Pledge of Allegiance? I'd just like to note one personal thing is many of you have sat in this chair as chair before, and many of you will sit in these chairs in the future. I had the pleasure of being with Dan. I use the word pleasure because if you know the man, even in those tough times, he was still smiling and talking and very much at peace with himself. Robert called me, and we met up here with the family, and I went in to see Dan, and he made this comment. You know, he always very respectful of the position, not of me, the position. He said, "Mr. Chairman, I may not be at the next board meeting." And I looked at Dan, and I said, "Dan, you'll always be with us in our board meetings." So in that light, I would like to ask us to take a moment of silence in his honor and memory. And likewise, as Robert says, we feel like we lost a family member. And again, thank y'all so very much. Let's do that now, and then please join me in the Pledge of Allegiance after that. Again, thank y'all so very much. If you please join me now. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Robert.
You bet.
The next item is item number 3. I have been advised today we have 2 individuals, citizens, that have signed up for speaking today. I will call them up as they listed on their sign-in sheet. Before we do that, I just have to always remind everyone the comments are to be in accordance with the Board of Managers standard operating procedure. Each person who wishes to address is signed in today, and each of those individuals will be allowed 3 minutes to make their presentation. And so, again, we will start that presentation when they reach the podium, and for their, I guess you'd say, convenience, the 3 minutes is up on the monitors, which will give them an opportunity to monitor their comments within that time frame. So the first individual today is Lee Crosby, and if Lee could come forward. Lee.
We put the 3 minutes up for those who are farsighted and nearsighted.
Excellent.
We just wanted to make sure.
Yeah, I mean, you can't miss it. Yeah.
Anyway, Lee, the podium's all yours.
All right. Thank you. Good afternoon, and thank you all for the opportunity to comment on matters relating to John Peter Smith Hospital. I'm Lee Crosby. I'm a registered dietitian with the Physicians Committee. We're a nonprofit of more than 12,000 doctors, including 101 here in the Dallas-Fort Worth area. And I wanted to talk to y'all today about food. So I recently read an article in Food Service Equipment and Supplies magazine that is a page turner that praises John Peter Smith Hospital's recent kitchen upgrades. It allows the hospital to offer more menu items that are healthful, including vegetarian choices. And I want to applaud you for investing in the health of your hospital staff, visitors, and patients, because numerous studies show that people who consume plenty of vegetables, fruits, beans, and whole grains are likely to weigh less and have lower risk of heart disease and diabetes. Moreover, many people look to their local hospital for guidance on adopting a healthier lifestyle, including good nutrition. John Peter Smith Hospital has the potential to become a leader in preventing diet-related diseases in Tarrant County. However, there is one change the hospital should consider making. On the first floor of JPS Hospital, a McDonald's restaurant offers cheeseburgers and greasy chicken and other unhealthful fare. Now, my organization obtained the hospital's contract with McDonald's, and it ends in August of 2019. So I'm here to say, if the fast food chain leaves that space, would you consider expanding your cafeteria? You could increase the number of healthful, plant-based options available to staff, visitors, and to patients. In fact, several hospitals have already closed McDonald's restaurants, including plenty of large public hospitals, Parkland Hospital in Dallas, Grady Memorial Hospital in Atlanta. Because in addition to often causing weight gain, consumption of burgers and shakes and other fast food is linked to an increased risk of heart disease, and the risk increases as people eat more and more fast food. So specifically, a study published in the journal Circulation found that people who eat fast food just one time per week have a 20% increased risk of dying from heart disease. That's just once a week. 2 to 3 fast food meals per week, that risk rises to 50%. And eating 4 or more fast food meals per week is linked to a nearly 80% increase in risk of dying from heart disease, our #1 killer. On the flip side, it's important to note that many plant-based disease-fighting comfort foods are both appealing to patients and affordable. Thank you for considering my comments. I'm happy to answer any questions.
Lee, thank you very much for your input. As you know, we cannot comment, but thank you very much for your input. Appreciate it very much. Thank you. The next individual who signed in is a face is familiar. I would call on Mr. David Salisbury. David?
Thank you, Chairman Powell. There are probably many days you would like to have had a 3-minute clock about 5 years ago, but I'll be brief here in my comments today. I really come to you, to the board, to Mr. Powell, and really to public acknowledge a thankfulness to Robert Early, to Sharon Clark, and many other people at JPS who work and help work to pool supplemental funding, Medicaid supplemental funding, into Tarrant County to support care for both the Medicaid population and those who don't have insurance. I'm a healthcare advisor now who works with Texas Health Resources locally and many other organizations across the country, and I can tell you by far the cooperation that's given in these discussions and in these programs from JPS with their partners in the community is not comparable to any that I've seen anywhere. And I just really want to and sincerely just say thank you to the team, to make sure the board knows that, as you know, these are funding discussions about incredibly complex programs that have requirements that aren't always necessarily clear and timelines that aren't necessarily very achievable. But somehow we found a way to make them work as best we can. They never fully meet the need. As we all know, the need certainly always outstrips the dollars. But again, it takes a local cooperative to make it happen. And I can tell you, we're clearly a fine example in Tarrant County of doing that. So again, I just say thank you to you all, and appreciate the work that you all have to do to consider these programs and make decisions. Thank you.
Thank you, David. Appreciate your kind comments. That being the citizens wishing to address item number 3, we will now move on to agenda item number 4, which is the approval of minutes. July 13 minutes were provided to you earlier. I will remind you that these minutes are fairly lengthy because that was a joint meeting, not only of the Board of Managers, but also the Medical Executive Committee. Dr. Ziegler was here to present that and with the Medical Executive team. So if there's not any questions, I would entertain a motion. A motion?
Mr. Chairman, let me
Yes.
comment before you call for the vote. What was posted on the board portal last Friday has been corrected since then. There were a few minor corrections, but the most substantive correction was in the last motion dealing with the purchase of the real estate, was actually putting the language from the motion that Mr. Petty made word for word in the minutes, and that's the only substantive change. Okay.
Okay. That being said, then I have a motion and a second. All those in favor say aye. Opposed, no. Thank you very much. Next item, speaking of the medical executive staff, I will call Dr. Ziegler.
Thank you, Mr. Powell. Nothing to report this month. Next month, we're hoping to have a short proposal or short presentation.
Okay. So nothing there. All righty. Then I'll move to item number 6, and we'll first deal with item number 6A. As chairman of the Board of Managers, and based on the recommendation of Robert Early, President, CEO, and the advice of Neil Adams, General Counsel of the Hospital District, I will not call a public hearing today as required by Chapter 298B of the Texas Health and Safety Code to consider 2 issues: the amounts of any mandatory payments that the Board of Managers intends to require a provider participate to make, and how the revenue derived from those mandatory payments is to be split and spent. Those 2 issues will be addressed by the Board of Managers in a subsequent public hearing called by the Board of Managers on or before August the 31st, 2017, for the purposes of considering approval of these 2 issues. So that is in regards to item 6A. We will be getting on the calendar when that meeting will be, and we'll be getting that information out to you as soon as possible. Moving forward under item 6B, I will now move and ask Robert and I think some legal counsel to make their presentation, and I'll turn it over to you, Robert, this time.
Thank you, Chairman Powell. What I wanted to let you all know is the aspects of the LPPF, as it's known. This local provider capability to pull additional funds down from Washington to use for healthcare purposes was initiated in the state of Texas some years ago, and it was initiated primarily for those areas of the state that did not have a public hospital. Public hospitals are the best conduit and the easiest conduit to use intergovernmental transfer funds to match funds to pull down from the federal government for healthcare use. There were probably, and don't hold me to this, probably 6 or 8 different entities in the state, predominantly in rural areas, that did not have a public hospital. Parkland and Bexar County and us began to talk about, can we utilize that capability to create not only greater capabilities, but also help our colleagues in the industry, our private and not-for-profit colleagues, to be able to enhance funding for that population that has such a struggle with its funding of healthcare. And it was an opportunity for us, and we saw that opportunity as a way to help the community. So we got together with some of the folks primarily at THR, because they became the voice of the private hospitals in this particular issue. Mr. Salisbury in his role and a few others, to try to talk about how best we could do that. It then became a piece of legislation that I briefed you all on 4 different occasions as to where that legislation was. That legislation took a variety of twists and turns, as any piece of legislation will do. It all made us want to go back to 8th grade and remember what we had learned about civics, because every different course it took was one little nuance to it. But the bill passed, and so we have that capability and that process. This organization, predating me and predating the last CEO, had the foresight and the intelligence to bring in Mike Spivey. Mike Spivey is, I think, probably one of the national leaders on these type issues. He has a mind that is helpful to try to figure out what you do. He's worked in other states. He resides in Washington, D.C. I don't know that just helped you. I think that probably just hurt your credibility immeasurably. I probably should somewhere else. He lives in Maryland. Let's try that. Mike has been helpful to this organization in the time I've been here, and Neil has known Mike longer than I have. And so Neil and Mike have worked together along with me and staff to try to figure out how best to do that. What I would like to do is have Mike Spivey come forward and give you just a brief history of this situation, intergovernmental transfers and what that means, because there are different buckets of money here. Let Mike go through a brief overview with you as to what this is and where we think we're headed and why we're headed there. So with the exception that I said you were from D.C., Mike, why don't you tell us a few?
Worse, you could have said I was Washington lawyers.
Yeah, exactly. Yeah.
Mike, push your button where that green light is.
That mic next to you on your left.
There you go.
Hit that.
There you go.
And that should be green. I don't know the difference, but I think it's green.
Got it. Thank you. It's a pleasure to be here, Mr. Chairman, members of the board. I'm going to be relatively brief. I want to give you a little bit of background about the LPPF program, Local Payment Provider Fee, how it works, why it works, and then talk about actually a couple of different transactions involving that. As Mr. Early told you, this program is actually not new. It's existed for a while in other parts of the state. It's new to JPS. This is the first time that we will have the opportunity to do it here in Tarrant County. But these kinds of funds exist, as Mr. Early said, primarily in rural areas of the state, and they have been implementing and operating these kind of funds now for several years. This last legislative session, there was new legislation introduced that passed that granted urban areas with a public hospital district the authority to implement the same type of fund. In order to implement the fund, the public hospital, Tarrant County Hospital District, has to authorize the program and then must comply with both requirements under the state legislation as well as requirements under federal law. And I will talk about both of those in just a moment. That's a bit of the brief history. Why do this? JPS has been involved in making intergovernmental transfers on both its behalf to fund payments that come to JPS as well as on behalf of private hospitals now for almost 20 years. I first actually got involved with JPS in 1991, and that's when we implemented the first disproportionate share program, and that was the first year that you made intergovernmental transfers to support those payments to JPS. And over that period of time, those programs have expanded, they've changed, they've modified. We've gone through a Section 1115 waiver that has changed the nature of some of those payments, but through it all, JPS has made intergovernmental transfers to fund the state share of these various programs. So why this? Why now implement this kind of program? The short answer is because there is no more capacity at JPS to use governmental funds to transfer on behalf of private hospitals and support these payments, and therefore this mechanism of creating a fund where private hospitals will pay a fee that complies with state and federal law that JPS then can use to transfer means that JPS doesn't use its money, doesn't use taxpayer money, uses money coming from those private providers to fund the state share of the additional payments. Now, the impetus to implement this fund is actually occurring in the future. The state has proposed to implement a new program that we haven't seen before, not a DISH program, not a UC program, but a program involving enhanced payments flowing through managed care companies. And so in the spring, if all goes according to plan, the state will implement rules for that program, allowing JPS and others to transfer money to the state to support increased Medicaid payments through the capitation rates being paid by those managed care companies to providers. At that point in time, JPS will be able to intergovernmentally transfer its own funds, your own governmental revenues, to HHSC and receive additional managed care revenue as a result of that transfer. This legislation was intended then to allow JPS to assist the private providers so that they also have access to those increased managed care funds. So JPS at that point in time will actually make two intergovernmental transfers. It will make an intergovernmental transfer on its own behalf to pay for the state share of the increased managed care payments to JPS. It'll also make an intergovernmental transfer from revenues that are in the LPPF in that fund to support the state share of increased payments to the private hospitals. So you will finance your own payments, and with no money of no JPS or taxpayer dollars, you'll use private fees to fund the state share of payments to those. We have a lot of work to do before April to put all that in place. We don't even have regulations yet to govern the program, but optimistically we'll get all that done, and hopefully JPS will see some increased revenue in the spring of next year from that program. So that brings me to the sort of immediate current transaction, and that is for increased UC payments to private hospitals. The way I would describe the transaction, which includes materials in your briefing books, is that this is a one-off transaction. This was not the transaction that was envisioned when the folks behind the legislation created the LPPF moved that forward and got that passed. In fact, this is a recent development due to the fact that there are unused, untapped funds under the Section 1115 waiver. The state is not spending all of the money that it can spend for uncompensated care payments, and private hospitals, including those in Tarrant County, have the ability then to draw down additional federal UC payments. In order to do so, there has to be some kind of state funding for those payments, i.e., there needs to be an intergovernmental transfer. How do we get that intergovernmental transfer? Go ahead and implement the LPPF, levy a fee against those providers, collect those monies in the short term, and then use those funds for this one-time transaction to fund those increased payments to the private providers. Two more points, and then I'll be happy to take any questions you have. First point, as I mentioned at the outset, all this is subject to both federal and state regulations. In point of fact, the state regulations aren't really a problem because they, in essence, just mirror the federal regulations. The state, as part of the legislation that adopted this, included provisions that mirror the federal law requirements, provisions that are in the federal code regarding these kinds of funds. What do those regulations say? They say that any kind of fee that you collect, like this fee, has to be broad-based. That is, it has to include everybody. You can't just selectively impose a fee on providers. Two, has to be uniform. Everybody has to pay the same amount. You can't have some people pay more, some people pay less. And finally, the entity that's levying the tax cannot hold a taxpayer harmless. Stated differently, JPS can't turn around and write a check or do other things to one of the tax-paying hospitals to say, here's your money back, not to worry. So this program is designed so we comply with those federal requirements and in turn comply with the state law legislation that incorporates those federal requirements. Last point. No program of this type, in fact, no program involving federal revenue here is without any risk whatsoever. CMS can change their mind, change their rules, change the way they implement programs. They can decide that assurances they gave in the past now are no longer good. In fact, in the case of certain UC transactions in the past, the last year, CMS has come to the state of Texas and said, we are going to withhold payments under that program, and the funding arrangement you had is no longer valid under federal law. The state of Texas disagrees with that, and so we have a whole process in Washington to resolve those debates. But I bring that up just to say the rules change, programs change. It struck me in looking at this legislation and in talking with Mr. Early as well as your General Counsel, Mr. Adams, that a very important part of this program was ensuring that taxpayer revenues and that your organization, as recipient of those revenues, is not at risk in this program. That because all the funding is coming from private hospitals, if the rules change or if anything goes wrong, those providers will be at risk. And so, as part of your package, you're also seeing draft rules to implement this program, and they have protections to ensure that no taxpayer dollars will ever be used to finance this program in any way. With that, I'll stop and be happy to take any questions you have.
Mr. Chairman, let me back up what Mr. Spivey just said. We told you all I mentioned to you all at various times when this bill was being debated, that we would support this measure and we would want to be cooperative and supportive of our colleagues because this is good for Tarrant County. This is good for healthcare in Tarrant County. But at the same time, we are the only ones that are going to participate in this that have the taxpayers' money that we have to be genuine, forthright, and open with. So we would not ever subject the taxpayer dollars to risk or this organization to risk. One of the luxuries of the piece of legislation that they passed is allowing us, because we put up that IGT, to begin to write those rules, the rules that do that protection. And I feel very confident by our colleagues in the industry that they'll be very supportive of those because they want to support that as well. They see it as a benefit to them, and it is, but also they know that we have the responsibility of using efficiently as possible tax dollars money. So what we propose to you all today are a set of rules that Mr. Adams, Mr. Spivey from their levels, from the law, and I have looked at that protect JPS. We feel very confident we can go to the taxpayers of Texas and our Tarrant County and say we have protected your dollars. And so we devise for you those rules today, which we think put the proper protections in, and I'm thankful that the legislation gives us that capability. I'm thankful that we have that capability, so that's what y'all see here today. I know Mr. Adams probably has some comments, Mr. Chair.
Yeah, thank you, Mike and Robert. Mike and Robert and I have been working on this for several weeks in terms of what's in front of you. You have a blue folder in front of you, and let me tell you about the 4 documents you have in there. The first is a draft proposed motion. I'll come back to that. Last Friday, I sent you a proposed resolution, which does several things that are listed in that resolution that you saw with some 10 items. I'll come, that has been now, we're proposing in the motion that I'll come back to, an amended resolution. And what we've done is we've taken the 2 items that the statute requires that there be a public hearing, and that is setting the mandatory payment by the provider participants as well as determining the revenue through that mandatory payment as to how it's to be spent through the IGT. And you have a red line that shows, that's a red line of the resolution I sent you on Friday so that you'll know where the changes were. And then the last document is the actual proposed draft amended resolution. Let me go back to the proposed motion. It does 7 things. It creates the provider participation program consistent with Senate Bill 1462. You will be adopting a set of rules and procedures. Those are attached as Exhibit A to the resolution. Mr. Spivey and I have spent a great deal of time on those rules and procedures, and Mr. Early has signed off on those. Let me just reemphasize what Mike has said and Robert. The way these rules are drafted, there's absolutely no risk to the hospital district. You will receive annually under the statute $150,000 administrative fee. But Mr. Early, who will be doing the IGT in behalf of the district, has no authority under these rules unless the providers have paid wire transferred all the money into the local participation provider fund. It also requires the providers to provide financial data that has not been the case in the past, and by statute anyway, or rule. It also selects J.P. Morgan, our current banking arrangement, to be the depository. It creates the local provider participation fund. It authorizes the board of managers to do whatever is necessary in order to comply with this new statute. And it authorizes Robert Early to make the IGTs. That's the draft of proposed motion that adopts the draft, the fourth document in your packet, which is the amended resolution. Mr. Chairman, I'll turn it back to you. Unless somebody has questions.
The other thing Mr. Adams has that I think is important is the vested power of all this is within you as a board. I don't have the ability, when you pass the rules today, I don't have the ability to change those rules. Those rules are what we told the public. Those rules are what we've had in a public setting. I think that's positive. So you have the confidence that I, as a CEO, don't have the ability to go amend those rules or change those rules in any way. Again, it's for the protection of that tax dollar and the protection of what we're doing.
If I could just say, excuse me, if I could just say one thing to the board. As you recall, we've had several prior discussions on this. I think, correct me, Robert, probably all the way back to March, you probably first brought this up with me. Mike, you probably, was it House Bill 1462 or something, or whatever? Senate bill. And so this had a whole lot of stuff going on with the legislative session. And throughout all that, Robert has always said that, one, that we would not put taxpayer dollars at risk in this program. And that's what the board's been told, and I think this adequately, between Mike's recommendation and general counsel of the hospital district, that we are not doing that. So, Robert, I think that is one of the primary things. The other thing is that, and Mike, you may clarify this a little bit, you said this was a little bit of a one-off. Once that program, I loved your words, I think you used optimistically, see us getting some money next March with our own IGT. I guess my question is, what we're doing here allows the other hospitals within Tarrant County to draw down those unappropriated, unused funds. I may not have the legal terminology right, but there's funds available. And we're being asked at this time to kind of speed up, because originally in our initial conversation, we told this board that all this would be coming through and we'd be dealing with this maybe next spring, because we'd be at the table getting money from when we put up our IGT. But we are truly doing this in really in a collaborative effort to help or to assist, and why miss the opportunity to bring these dollars that the privates are putting their money up for? If they can IGT it, those dollars are coming back for health care needs in Tarrant County. Did I say that right?
You did.
Okay.
You did.
Again, this is not something that just kind of, JPS was going along, we kind of had our, we kind of had our roadmap where we were going, and then because of these funds becoming available, we were asked to step up, and I think the entire, since day one, as long as there's no tax dollars at risk, and we can do this to assist our other hospital partners in this county, I think that's what's before us today. So, again, Robert, you kept us surprised the whole way. It's just kind of, we had to speed up the process. So, go ahead, Neil.
One other comment. The reason I put the red line document in there, those are going to be back in a second resolution when we have the public hearing on these two issues. They will be included in another resolution to be adopted after the public hearing. That needs to occur on or before August the 31st of this year. When discussing Mr. Rule and Mr. Early, we're looking at possibility, and Mr. Powell, sometime the same day we have the Finance Committee and the Governance Committee meeting. either right before or right after. So we'll need to have a quorum of the board present for that public hearing. So that's what the red lines are. You'll see those again.
And as indicated,
Yeah, exactly.
Yeah.
And those numbers may change.
that's correct.
Okay.
As I indicated, this has kind of moved forward relatively quickly, but when we have the hearings, we thought, and Steve, you chair finance, but we thought that day would be a good day to have that public hearing. So we'll get back with everybody and make sure that fits everybody's schedule, because obviously we'll need a quorum. Dr. Lowry.
Mr. Chairman and Mr. Adams and Mr. Spivey, just for clarification from me, and I notice it's been pulled out in red line, item 2 and item 5 discuss institutional health care provider. For clarification from my mind, we're using provider with the small p, meaning every
Non-for-profit.
doctor, nurse practitioner, whatever?
No.
Or the bigger P as in the different health systems? It's the bigger P, if I may use that term?
Only hospitals. So under, and I didn't get into the technicalities of this, but under federal law, levying fees, there are categories of providers. I mentioned it has to be broad-based. So the physicians are a different category, nurse practitioner, different category. So we're talking about hospitals within Tarrant County.
Okay.
That phrase refers to those.
Thank you. For me, I'm picturing every provider, physician, nurse practitioner,
No.
providing all that data. It's not going to
No.
be that mammoth a deal.
No.
Thank
But I
you.
will say that was probably the single best answer to the question, is this a big P? Your answer was probably the best I've ever heard. That was really, really good.
Thank you.
Acute and rehab hospitals also as well?
Yeah.
Is there any other questions for Mike or Neil or Robert on this matter?
I'll be,
Go ahead, Ralph. Go ahead.
There's going to be a motion before us today.
Correct.
That motion before today, what effect does that have then on the public hearing?
That has no effect on the public hearing, because what you're adopting today is authorized by statute to be adopted by the board without a public hearing. The two items that we pulled out that Charlie had mentioned, which was mandatory payments and the revenue and how it's spent, have to have a public hearing, and that's what will occur on or before the 31st. What you're doing today is creating the program, adopting the proposed rules and regulations, setting the bank, adopting the bank account and that kind of, and creating the fund.
And Pastor Emerson, from looking at the statute, the way it's written, the public hearing portion is to always be transparent, particularly the rules that we set up in Texas, always be transparent anytime a taxing capability is around. That's really what the public hearing deals with, to let the public know that even though these hospitals will be taxing themselves, it's still under the statute of the state of Texas, a tax, and the citizens need to know that's going to be levied. It won't be levied on the citizens in any way. It'll be levied based on what the hospitals will put forward. That's the purpose of the public hearing, is that portion of it.
I'll put forth a motion, so.
Excuse me, go ahead, Warren, I'm sorry.
Quick question. So it is not presumed that every hospital is going to have to pay this if they don't want to participate. They only pay this mandatory if they participate, right?
No. Everyone, every hospital within Tarrant County has to pay the fee if the fee is to be valid under state and federal law. The fee has to be broad-based, which means that every hospital meeting that definition of hospital, acute or rehab, within that category, has to pay the fee. If someone says, I don't want to pay the fee, I'm not going to pay the fee, then the fee is not permissible under federal law, and the funds generated by the other facilities cannot be matched with federal money.
But in this process, Mr. Murray, we, at least from our colleagues in the industry, they have a unified voice in what they've represented to us, but we're not interested in moving forward if there's discontent amongst private hospitals. That's not our place. Ours is to say, if you have a unified view of this, if you want to pull this money down, we will help enable you to do that. So this isn't a forced type situation. We wouldn't move forward if there's 6 or 7 that say, no, we won't want any part of this. This is a positive from what we've heard from our private and not-for-profit colleagues.
I just want to make sure I understand. So have we gotten?
Turn on your mic. So.
My mic's on. I'm just not being loud enough. I know it's a problem all the time for me. So is it being told, am I being told today that there are 46 organizations in Tarrant County that will be hit with a tax if we do this? Probably, assuming that we adopt a non-zero tax, and that all of them have affirmatively stated to this body or to somebody that's collecting the information that, yes, they want to be part of this.
That's pretty much been represented to us, that would be the case. If it gets to that point and there's disunity and there's a bunch of saying, no, we don't want any part of this, it's not our fight, and we wouldn't move forward. This is something that is beneficial, and they see as beneficial to them. The fee capability of this is something they wanted and asked for. The other thing, Mr. Norad, to give you evidence of this, is when the legislation went through its process, there was no opposition. It went through a lengthy process from the House and the Senate, and nobody locally said, we're opposed to this. We don't want any part of this. They all said, we are very supportive of this from my standpoint.
Well, this is my problem, and I'm people have lives and they're running a business, and they don't pay attention to the comings and goings of the state legislature. They just hope that they don't get kicked too hard along the way. And so I'm sure that Baylor and Texas Health and all of the larger organizations are all on board. They have the structure, and they are well prepared to add this little level of bureaucracy to handle this issue. But I don't know that every organization here, and I don't know that we have to say we're not going to do it unless everybody is on board, but I'm leery, in fact, I'm weary of public officials telling me everybody's on board when what we've done is we've talked to 2 or 3 big players in the industry. Everybody else is trying to make a living, and they haven't had time to register their displeasure at this new tax.
Sure.
And so, not that I'm going to call 46 people and say, hey, are you on board with this? But I would welcome an opportunity to somebody to show me that actual real input has been solicited by all of these organizations, because that maybe everybody's on board. And
So the legislation actually requires us to provide notice to all 46 that we intend to do this. At that point, I mean, the representations that have been made to me as well are that the 46 organizations there are supportive of this. However, there's one more step, which is why you're going to have one more meeting about this. You will have to send a written notice to a representative of each of those saying, this is what we intend to do, and this is the proposed tax rate, and this is the proposed liability for your organization. Let us know if you have a problem with this. So at that point, before we have to make an IGT, you're going to know whether you really got 46 or not.
We don't want you in any way to be weary or leery. And
You're late on the first.
The other point, I do want to strike I do want to mention the irony that I have become the voice of the unified voice of private hospitals. I do not speak for them. I appreciate working with them, and I enjoy that. But at least everything we've had up to this point has been exceptionally positive. Don't want anybody asleep at the wheel, and to Mike's point, when those notices go out, everybody will be informed, and it won't be informed at a statewide level. It's very local.
Also respond to that, Robert. If you'll notice on the red line document, that's redlined out, Warren, the Exhibit B, which has the various numbers by each of the 46 providers. That is going to be addressed in the public hearing.
Right.
They will get written notice from me as required by the statute, sending them that notice. And so they're going to be aware that there's going to be a public hearing. I have asked Mr. Salisbury and Carlos Zaffarini, who is also representing the group of privates, to forward me the contact information as to who should get that public notice, so that each individual hospital is not going to be surprised by anything. They're going to get something in writing that says, hey, there's going to be a public hearing. Do you want to be here, and do you want to participate? That's the second vote. What you're doing today is just creating the program so that opportunity's there. Okay?
Creating opportunities, that's all we do. Thank you.
What is it?
Warren, I'm not asking if you're weary. Are you okay? Anything else? All right. Any other, DT? I'm sorry.
Question, so the IGT dollar amount, is that the 46 million that we're looking at on the last?
Those
page?
numbers may change.
may change.
They may change.
Is that
So
the number that we write the check and then
we
get
don't
reimbursed?
provide any dollars.
We
These
just do
dollars are
pass-through.
coming from the privates.
Okay.
They're going to pay it into a fund. There's going to be an IGT out of that fund, and you'll have no taxpayer dollars in that fund for this particular item.
Right. Is 150 enough?
That's what the statute requires. That's the maximum you can get.
I asked that too, DT. But that is by statute.
That's by statute.
That's right.
That specific dollar amount's in the
If it goes
statute.
over, then it will be.
It's an annual fee of $150,000. So.
And like I say, I truly believe this is a collaborative effort. We're coming and doing something. Let's make this point very clear, Warren. I agree with you. There's another vote that's out there, but we are doing this, enabling the privates to pick up a considerable chunk of dollars that are available that they can bring back to Tarrant County for healthcare needs throughout this county. Are those direct dollars coming to JPS? The answer is no. The main provision here that my conversations with Robert and his conversation with Mike and with Neil, the reality is, if you remember way back, there may have been some language, Mike, again, correct me, we read all those preliminary bills, we never thought it was going to pass. I mean, we didn't know it was going to pass or not. And, but at the end of the day, once it passed, there was some comment in there about collection, about we had the right to collect. Well, I'm sorry, the profession I come from, usually if you're collecting something, there was some risk involved. And so again, I think on behalf of the board, that council and along with Mike, Neil, and Robert, your input, that it is buttoned up where that I hear general counsel of this hospital district and a man that's been doing business with this hospital district a long time, seen as a national expert, we shouldn't have any risk to our dollars. We're not sending money out unless all their money is in the pot, DT. That's
correct.
That point is pretty black and white, so, okay.
And it's got to be wired transfer by the rule. It's not going to be by check or anything else.
Yeah. So anyway,
I have one question, just for my.
certainly, Chuck.
Does this in any way, shape, or form impact or change what we currently are doing with IGT?
No, it will not. Those are going to be separate. Mike, I don't know if you heard, but the question is, does this affect our other IGTs? And the answer to that is no.
No. Any other discussion? Oh, sorry, Warren.
You're doing fine. We talk very often about how complex healthcare is, such that it takes, who knows? But whenever we talk about the reasons it's complex, it's because we do things just like this. We take federal dollars, we funnel it a certain way, through a certain way, and out in a certain way, and suddenly we've got people in Hawaii paying for a tooth be pulled in Tarrant County, or something like that, and it's nuts. I'll just leave it at that. So, thank you.
Okay. Any other discussion? If not, I'd entertain a motion.
I'll move, and I apologize for the length of this motion, so grab a cup of coffee. Here we go. Mr. Chairman, I move that the Board of Managers, based on the recommendation of Robert Early, President and CEO of the Tarrant County Hospital District, and with the advice of Neil Adams, General Counsel, the Tarrant County Hospital District approve the amended resolution implementing the requirements of the Tarrant County Hospital District's participation in the Healthcare Provider Participation Program that, number one, creates the Tarrant County Hospital District Healthcare Provider Participation Program. Number two, adopts the Tarrant County Hospital District Healthcare Provider Participation Program rules and procedures attached to this resolution, and identified as Exhibit A, Tarrant County Hospital District Healthcare Provider Participation Program Rules and Procedures. Number three, requires each institutional healthcare provider to submit to Tarrant County Hospital District a copy of any financial and utilization data required by and reported to the Texas Department of state health services under Texas Health and Safety Code Sections 311.032 and 311.033, and any rules adopted by the Executive Commissioner of the Texas Health and Human Services Commission to implement those sections. Number 4, designates J.P. Morgan, located at 420 Throckmorton, 4th floor, Fort Worth, Texas, 76102, as the depository for mandatory payments received by the Tarrant County Hospital District. 5, creates a local provider participation fund. 6, authorizes the Board of Managers of Tarrant County Hospital District to take all other actions necessary to meet the requirements of Chapter 298B Texas Health and Safety Code. And number 7, authorizes the President and CEO of the Tarrant County Hospital District to make intergovernmental transfers, IGTs, from the Local Provider Participation Fund to the Texas Health and Human Services Commission based on the Executive Commissioner, Texas Health and Human Services Commission schedule of requested IGTs for uncompensated care payments.
Any questions on the motion?
You need a second.
Yeah.
If there is,
Your next motion is War and Peace.
Yes.
That was very well done.
I have a motion. Do I have a second? Have a second by Mr. Montgomery. All those in favor say aye. Aye. Opposed? Thank you very much. There was a no. Got you. Tammy, did you get that? Okay. All right, we will now move forward to item number 7, which is the consent agenda that's been on the portal and you've had opportunity to review, and if there's any comments relative to what's on the consent agenda. If not, I'd entertain a motion on the consent agenda. I have a motion by Dr. Weber. Second by Mr. D.T. Wynn. All those in favor say aye. Thank you very much.
Mr. Chairman, I wish to abstain from that vote
Okay.
for personal and professional reasons. Thank you.
Thank you, Tammy. So noted. Thank you. We will now go to item number 8 on the agenda, which is, I will call Sharon up, and we will get into our budget discussion. As Sharon's coming up, I want to thank Steve, Sharon's staff. I know, Steve, you've had several meetings. I know I attended one last Friday for several hours. I know a lot of work went into this. I want to thank you and the Finance Committee for the work y'all did also, so thank you.
Coming out. Yeah, that's right. I keep forgetting.
Y'all just went through the shortest part of the meeting, by the way. Just wanted to let y'all know. Now,
7 p.m., right?
yeah, it's always a good way to start.
The expectation, and anything will be good from here.
Exactly.
Just teasing. So, if you guys have any questions about anything during the budget, this will be a long presentation, hopefully not as long as I'm thinking the medical center will probably take about an hour and 15 minutes to get through. I appreciate an interactive presentation, as we always have, so please stop me and ask questions. It makes it a lot easier for me. I think it makes it a lot more interesting for you guys. I have given this presentation several times, and every time I give it, people have a different perspective, and it makes it more fun for me to give it. Now, I've talked to several of you, and so I'm going to try to weave in a couple of your concerns and comments throughout this presentation, but I really appreciate each and every one of your perspectives. So again, please ask questions as we go along. Kind of feel like I'm sitting under a spotlight today. But as Steve and I were having lunch today, he asked me to spend a couple of minutes reminding you of how the budget process goes. And I forget in my role that you guys don't prepare budgets every year and that you are not involved in our budget process. All of these folks that work at JPS that are sitting behind me are involved in the budget process. So for all of you that are behind me, that had a role in the budget process, can y'all just stand up? Everybody. Bill, you can stand.
Sorry, what?
I guess, thank you.
So, and they're not just involved. I mean, they really do the budget. Finance coordinates it. We give them a lot of information. We talk them through a lot of things. We set some goals. We drive them crazy. But finance does not do the budget. At least that's my perspective. Every person does their own budget. Every department director, every manager is involved in the budget. We don't go in and pull last year's budget and kind of dust it off and do a few updates. We actually create a new budget every year. We start in March after we have 6 months worth of actual information. We start to look at volumes. We try to figure out what's going to change. Do we have a new physician group coming on? Do we have any significant retirements that have happened? We start to look at new technology. Have we purchased new technology? Are we thinking about bringing something new on? Do we have a new site? So lots of work goes on. We involve key medical leadership, physicians. We think about what's going on with a claim. How is that going to impact what's happening with the medical center? How is what's happening at the medical center going to impact a claim? There's a lot of intercompany interactions that are happening. So by the time we get through the medical center today, I really don't think that us walking through a claim is going to take very long, because we've already talked about 80% of a claim. So just kind of enjoy what we're going to be talking about today. There's a lot of strategy, and again, ask questions as we go along. So, and from my perspective, the budget is the financial plan that really supports the operational plan. And it's also the financial plan that helps keep us around for the next 5 to 10 years. So we really pushed ourselves very hard. It was a difficult budget. It's like, that is not a good sign.
Sharon,
Yes, sir.
before you get started, I just need to know,
Oh, it's not.
the presentation that we're receiving today, once that's completed, then there will be a request to adopt? Or is this a work session on the budget?
That is going to be,
That is very much, and I
Your-
don't mean to interrupt you in any way, it's very similar to what we've always done in the past under your leadership and the other chairs, and that is, this is for full discussion. If this board wants to vote for the budget, certainly can. If the board would like to postpone the vote and deliberate longer, certainly can. If the board would like to say, no, we don't like this budget, go back to the drawing table, all those are within your prerogative. Nobody, there will be a potential vote whichever way you want to do it. So this could, the vernacular's not as important as to whether it's a workshop or not, but it is, in every intensive purposes, a workshop like we used to hold on Saturday. And what we had historically done is had that workshop and then voted up or down on a budget. It's the same process today. We'll discuss it, and then from there, once this board approves its budget, it will go before the Commissioners Court. And Sharon and I have meetings with every commissioner to go over where that budget is. It's always a challenge, because you always try to figure out sorry for the vernacular of my world, but cart and horse, and which is first and what is not. So it's always been our attitude that this board review its own budget, and then we take that, what is approved, to the commissioners and say, now, let us analyze for you what this budget is and let you weigh in so that when you as a commissioner have to vote, you can see fit whatever you would like to do. So I didn't mean it to be long, but this is whatever you want it to be.
Robert, any vote that's on this is going to be a recommendation to the county commissioners.
To the county commissioners.
Yeah.
Okay.
Having said that, I've talked to some people about that. This is what happens. We provide what we call a recommendation, and we kind of treat it like, well, it's only a recommendation, so it's no big deal. Well, it gets to the county commissioners, and they say, well, it's a recommendation from JPS Board of Managers. They know what they're doing, and they don't rubber stamp it, but they don't look at it as closely. And so both parties are kind of going, well, they're the ones with the ultimate, the ultimate say, therefore, we don't really have to pay that much attention to it, or as though it's not that big a deal. And I'm not saying that there's not anybody paying attention to it. I'm just saying that, yeah, what we do here matters. So, thank you.
Well, and I would emphasize that there isn't a single one with the weight loss program that everybody that stood up has been on for the last 3 months. No one takes it lightly here. And the other thing the only part of your comment that I would boldly slightly correct or amend is we don't take it casually in any way that, okay, we've done it, commissioners, you do as you wish, we don't really, that is of the will of any of the commissioners, and I think they take it, my understanding and what I've interaction with them has been very seriously, but we do take the process very seriously and the process by which they look at it. I don't know that any of our attitudes here, and I've not seen expressed from them, maybe from a cynical side possibly, but I've never seen anybody say, oh, you guys have already done this, who cares, or we're taking it casually. I've not witnessed that. But your point is understood. I just wanted to share my opinion.
I was going to talk about my fellow board members. Not that anybody in particular does that, but sometimes we last year at this time, the comment was made was, well, this is just a recommendation. That's
Sure.
an actual quote by more than one person.
Sure.
On the board.
Well, yeah, I want y'all as board members to know that Mr. Norad made that comment, not me. No, I'm just kidding.
Well, I'm sorry.
It wasn't either one of them. I think it was here related.
Yeah, exactly.
And I'm not trying to eat into your hour and a half. The reason I ask.
No, we're just adding to it.
The reason I ask is because in past meetings, we've all concurred that a specific meeting would be devoted or would become prepared to discuss budget. And I just didn't recall us doing that at any previous budget meeting. And then I see that on the agenda that we are looking at the budget. That's just kind of surprises me today.
So in prior years, what we've done is we've talked about budget processes, but we've never, so this year we did not go over again what the budget process would be back in May, because the budget process itself did not change. And then last Finance Committee, we went over some of the budget highlights, and we talked about where I expected to end up, projected 17, where we expected to end up the year. So today, we're going to be talking about those highlights. You've seen a lot of what's on this page, and the specifics of the budget. So again, even though this is an annual budget, I think a big part of my responsibility in the planning process is to make sure that from a cash standpoint, that JPS and the district stays whole and financially healthy in a 5 and 10 year standpoint. So when you look at us on a combined basis, and that means from a claim and the district, I think it's incredibly important, and it's also one of our destination metrics that we have a positive operating margin. And right now, that 9th destination metric says that we should shoot for a 1% margin, and we were able to hit that this year. We're going to talk about that, and you can see that on the next slide. And I think that's incredibly important, and that made this year very difficult. And even though the hospital does not directly fund a claim, meaning that we don't, break them even on a financial statement basis, you'll see that on the next slide, that we were able to cash flow the entire district. The ad valorem revenue is based on the certified tax rolls. You'll also notice that we really focused on the top side of the financial statements this year. We focus on a few revenue cycle opportunities that we had, and we're also watching denials management. We are looking at unnecessary utilization and care coordination. We also have some increased services, again on the top side. Through some contracts that y'all have approved, we have a new urology group that's going to be starting towards the end of this fiscal year. Our invasive lab revenue is growing with volumes there. And then remember that we closed T9 for a few months this year. We are outsourcing our SNF patients, which is a lower level of care. That's a skilled nursing facility. And we remodeled that unit. We have started to place general med-surg patients back on that floor. And we will have new capacity for a full year on that floor. So you'll see when we look at our patient volumes, we're able to accommodate more patient days there. We've also committed to labor productivity engagement. You're going to see some expenses for that, as well as some reduced labor costs throughout the year. And then this is important. We've talked about our DISRIP and Finance Committee. As we go into DY7 and DY8, DY7 coordinates with our FY18. They've changed our metrics around, and it did not quite coordinate with our budget process. But we do know that our DISRIP revenue is going to stay about the same. But because the metrics changed, we're probably going to have to move people around in departments and change the way that we account for that at the department level. So we're going to be asking you to approve the budget, and then we're going to be making some departmental changes. So we might have some categorical changes. We don't usually do that after you approve the budget, but this year we're going to be asking for that exception. It will not impact our bottom line, but just because of the timing and that legislative process, that's just one of those exceptions. Yes, ma'am.
When you talk about reassessing unnecessary utilization, give me some examples on what you are.
I've got a whole slide in that we're going to be talking about when I start to talk about that line item of patient revenue. So if we can hold that thought for a minute, I think I'll probably answer some of those questions.
So in the movement of some departments, or that's movement of dollars at the same time then?
Correct. We expect to receive the same net dollars. And we might have some changes between medical supplies or purchase service, but we're just not quite sure at this time because those metrics, as they change, we may just be moving between departments. I usually don't allow anyone to move between departments or between natural class categories after the budget's approved. But we may be moving those in September and October as we solidify those metrics.
And you'd bring that to Finance Committee?
Yes,
right.
Yes.
You talk about DISRIP being neutral, but everything I've always heard is that it's shrinking and going away. What gives you the confidence of leaving that as a neutral line?
Well, currently, we don't believe that that's going to be shrinking. And so as we work through that, every indication that we have so far does not make us think that those dollars are going to be shrinking. We still think that we're going to be able to get to the same level of achievement.
Okay.
And then the last bullet point there is our JPS Future Fund, where we have set aside and reappropriated dollars on our balance sheet. It doesn't really impact our operating income. When we get to the capital section, we're going to be talking about the Future Fund and maybe setting aside some additional funds for the master facility project, the bond project. So I just want to spend a few minutes on this. We're going to be going in in detail over the health network, which is the hospital, Acclaim, and the foundation here in a minute. But overall, the medical center has budgeted an operating margin of $23.2 million. That produces about a 2.4% operating margin. And the operating margin is just your gain from operations. It doesn't include your investment income, which we kind of call below the line. It's your operating margin divided by all the dollars that you bring in. So if you looked at your household, how much do you save? So it's 2.4%. Acclaim is operating at a loss of $2.3 million, and so a combined total of 11.1. So the combined total is what we were shooting for, our 1% operating margin. Now, I want to talk a little bit, if you'll indulge me for a second, about Acclaim and that $12 million loss. And I want to remind ourselves on the investment that we're making on Acclaim and the big benefits of Acclaim. Those physicians, right now, we have approximately 400 physicians in Acclaim that we will be onboarding. There's 394, and again, we'll be talking about that after I finish the medical center's budget. The loss per provider in that budget is just over $31,000. The MGMA median is just over $70,000. So for a hospital-owned physician group, we are doing much better than the nationwide average. Now, some of the drivers of the losses for a hospital-owned is mainly payer mix. For physicians that are private, they typically do not see self-pay. So, and then also within Acclaim, there are quite a few socioeconomic issues that may not otherwise exist in a private practice. Also, a lot of the ancillaries are hospital-owned. And this goes for any hospital-owned physician group. We also have benefit levels for staff. And we do have quite a bit of teaching and research that occurs for a hospital-owned physician group. So that's just kind of a reminder of what might be driving. And this is not just Acclaim specific. This would be for, again, any hospital-owned group. And then other benefits of Acclaim. Acclaim does manage the oversight of almost all of our patients that are seen within JPS. And as a reminder, we do have an integrated EMR for all of our patients, as well as the same billing platform. And then Acclaim also supports the overarching destination metrics and all of our quality standards throughout the district. So, but I do think from a combined standpoint that, you know, from my financial standpoint, that 1% operating margin was very important that we hit that for our budget.
So Sharon, and you probably have a slide on that, I guess. We're at the $12 million loss at this point. So there will be a slide or something that shows us where we're going to plug that hole, stop the bleeding.
You know, I don't know that you when you say you plug the hole, I think that Acclaim will likely never break even. I think what I just covered, you know, for most physician-based or hospital-based practices, we are operating at half the MGMA loss in the nation per provider. Also, the medical center itself is funding the cash flow of Acclaim. So looking at a combined total, we've budgeted a 1% margin. So I guess my concern is, you know, Acclaim is performing at a rate better than most of the, over half of the industry standard. And we, from a cash standpoint, the medical center is providing the cash to cover the Acclaim losses. You know, we've raised the bar on medical center performance as a district.
Let me, Pastor Emerson, let me make a comment, because what we do is, Acclaim has become a focal point of, I mean, when we describe it as Acclaim losing money, Acclaim was in a previous age JPS PG and UNT. If you looked at UNT's physician group and you looked at JPS PG and you had exactly extracted the numbers, you would see losses that were same or similar to that. This isn't a new phenomenon that all of a sudden we're losing all kinds of money in this. If you look at physician groups throughout the nation, you'll see a very similar pattern. And I think what might be helpful to you in future meetings is to do just that, is to take a few of the physician groups randomly selected and say, let us get the best information that they have and give you an idea of how we compare to those. It's not to tell you, isn't it great, we're operating at this level, but you should feel good because we're doing better than most of the nation. It's the nature of a physician group. It's not your moneymaker. In JPS's case, it's going to be compounded by the fact that everybody that comes in primarily to get their primary care are going to be non-paying patients. So you have an outlay of funds from the standpoint of the electric bill to the physician's salaries that you're going to have to figure out how one would offset that with a patient that oftentimes doesn't have the wherewithal or means to pay for their health care. So our challenge is, when you look at the overall budget, how do we make sure that we present to the taxpayers of this community that we have a balanced budget? And some of those may be doing better and some may be more challenging. I think in the case of the Acclaim Group, or previously known as Prince or JPS PG Group, it's the same kind of situation, and that is they face their losses as well. you have, in my estimation, in all honesty, far greater transparency into those dollars. Had we sat here and said, this is where PG is, you would have seen similar situations. So it's not justification for it, it's just to tell you the perspective.
Excuse me, Dorothy, I know you had a question.
Yes, maybe on looking at the cost for patient care, if we would start looking and identifying our total patient costs. I know you've got a cost system coming up.
Yes, ma'am.
Hopefully it'll be up soon. That might help us look at our total costs, and then we'd
Yes,
be
ma'am.
looking at which one are effective and what could we actually do? Is there anything we could do? And that might help us in looking at those costs. And since Robert said that a large number of our patients come in with no coverage, then we could, I would think we drill down and look at the JPS connection to see what our cost is there, because that's what we are mandated to take care of.
Yes, ma'am.
And so as we look at that, we'd be kind of looking at per member costs, and then we could compare, how do we compare to other groups? I know people gonna say we're not insurance, but for them, we really are.
Yeah.
And so that might help us in
mean-
identifying some of that cost, and if we could make that a part of our process of looking at that, that would help with some of the cost.
Right, Dorothy, I appreciate your comments. I'm also going to state that at the last finance meeting, obviously, we started talking about the budget issues. Chuck actually chairs a claim executive committee, and we'd asked Dorothy and Steve as chair of the district's finance committee, along with DT, and DT, you're out of town, but appreciate Steve and Dorothy being there. We got pretty much into those numbers. Again, there's been a lot of discussion about those numbers. I'm not putting words in Dorothy's mouth, but I think Dorothy stayed, because I was like, yeah, when are we going to stop? And I think Dorothy said, I knew going into here, this was going to be a long process, but when you were at the acclaim,
You're correct.
meeting.
We did
Yes.
see that as a part of the group that came in and presented us data on
Right.
looking at physician groups. We talked about, they compared the cost, so that cost was there. Then they was giving us some information about how you looked at that. So I think that's a piece that we need to look at.
Yes, ma'am, I totally agree.
Emerson, one of the things that is embedded within the claim budget, you know, we are constantly focused on how do you get that $30,000 per provider down, always. I don't know that that will ever get to zero, but, you know, the turnover cost is high priority, you know, physician turnover cost. After you get them recruited, how do you keep them? Continuing to look at productivity of a provider, that will bring the cost down. So I think those two things will help bring that loss per provider down. If you, but as far as, if you had to ask me, will that ever get to zero? My answer would be no, from an expectation standpoint. And that's why I think it's very important to look at that combined total from a financial health of the district. As long as you're looking at that combined total, and that combined total is at a positive number, then you're cash flowing the entire venture. You know, the hospital cannot operate without the support of the physicians and vice versa. So, you know, you have to look at it together. And again, I think that's, you know, that's kind of why I'm starting today with the combined income statement, because one can't go without the other. And as long as that combined total is at that 1%, then I think, again, that's the important number, not to discount one or the other.
As a point of clarification, may I ask, and I've not been involved with the acclaim stuff in any direct fashion, but my understanding or my thought is there are still physician groups and physician contracts that are not up under acclaim. There are outliers. a handful. Am I wrong?
The physician contracts that still lie within the medical center are more the coverage type contracts. It doesn't mean that they're completely outside the purview of a claim. It's just that the financial transactions may not be going through a claim. So there are no employment contracts that are not going through a claim. The major contracts are, none of the offloaded contracts that are going through TCICC that we're going to be talking about in a minute can go through a claim. So there are some major contracts that we don't plan to be going through a claim at this point in time.
They
Because
never
of
have
legal
been,
reasons.
and they still won't be.
Correct.
And we're going to hear about, without specific names of the entities, but services that are covered that way?
Correct, correct.
Thank you.
That doesn't mean that the quality and service doesn't, fall under the purview, and they're similarly, we expect same standards, but you just don't see them in the acclaim column.
I totally agree.
Yes.
One of the things, Sharon and board members, that we want to do, and I appreciate the dialogue from the questions, because that helps, and you never know where those questions are going to come. Sharon, you can probably,
The next slides are going to go a lot faster.
okay, I understand.
That's a promise.
Okay.
Because I know it's Thursday, and
All day long, until 5 o'clock.
All right, so I honestly think that this slide sets the framework.
Well,
I'm sorry, Warren, did you
Yeah,
comment?
My understanding, of course, I'm still the newbie, so don't
you are not a newbie anymore.
I'm
but
sorry.
you keep saying that.
Until somebody else is newer, I'm still the newbie.
Budget, Warren.
I understood a claim, to the extent that I understood a claim, to be a structure to manage HR issues primarily, and maybe I missed it, but I never heard anything about differing and incompatible medical record systems, or some of the things I'm hearing about now that are being used to say that a claim is a good thing. As I understood it, a claim was a method of putting together UNT and JPS physician group, and then UNT bailed, and then we were told of putting together different groups of physicians because it'd be easier to do it that way. And then recently, I thought I understood that we were seeing or recognizing losses that we'd always seen that weren't being accounted for by JPS, that physician group. And I can almost buy into that and I still may buy into that, if I could see that it comes out in the wash. If I've got one group that it's absorbing a cost, and then I separate the two groups, and I have to say, well, this group's going to have a bigger loss, I should see it coming out of this side over here. Now, I understand there may be some slop in the middle, and it's not easy to do these things. But not seeing $12 million that's a lot of money. And I'm not sure that if I were to see this version of this statement from 2 years ago side by side, of course, a claim wouldn't be there. Then last year, a claim would be there, but it'd be, what, $5 million, something like that?
Projected.
And now it's $12 million loss, and then it's a full-bore system. It's hard for me to understand what we're getting for this, what appears to me to be a more complex system that's more expensive. And if a claim is supposed to be about HR issues, it seems to me like a part of the conversation should be with the doctor groups. You got to use this medical record system. That's not part of a.
It never, yeah, I appreciate that. And one thing, and I think I'll take back my statement, I think you are a newbie in the regard that, and I don't mean that bad, I'm saying, I think.
I'll hold on to that as long as I can.
I think there's probably a need, not only for you, but for others, to go back to a physician group sort of one-on-one for all of us. It never was intended just to be an HR type situation. We had two different groups providing care at JPS that had two different directions. We had groups that would say, I'm not coming into my clinic today, and we wouldn't know it because they reported that back to North Texas. It's much more than an HR type issue. It's all encompassing, and it was an attempt to be unified with far more than just HR type issues, but the overall structure of care, quality, and what we did with that. And any reservation that you have towards the budget, feel free to not only express that, but vote that way. But I do want to have the best knowledge that you can have in front of you as to what a claim is and does, without any of the outside politics or anything else, because it was change, and anytime you have change, you're going to have some comments good and some comments bad. So strip ourselves of that and look at the purpose of a claim and what it does, and why we've done what we've done, and how that compares to best performing organizations, which we're trying to get to. So it is not the simplistic of this is really just an HR type situation. That is not. That is a misnomer. It's much more encompassing than that. And I think, as I mentioned earlier, if you were to look, JPS provided a great deal of subsidy to JPS-PG, and we took federal funds down and supplemented that in, and you never saw the losses because those federal funds went directly to PG. And it's not a fault of PG at all. UNT, we didn't know what the depth of their situation was, but we knew we needed 400 doctors. And if we had come to you and said, we've got 200 that we're going to incorporate, but we're going to get 200 locum tenens doctors, that would be horrible. And then the other thing is, if we didn't do that, or the situation that we had that was on the ground, we would have been in much worse shape. And I don't mean to keep saying, oh, you got it lucky, we would have been worse. It's just the reality of it. So I think, Mr. Norton, what would help you and others and me is if we maybe do an acclaim workshop. And it doesn't maybe help you today with your vote. That's why I said, with all due respect, vote as you see fit on this budget. If it doesn't feel good to you, or you feel that something's been wrong, or you don't even like the principles of a claim, that is a prerogative that I would respect. But I do think we need an acclaim workshop that just spends, I haven't discussed this with the chair, and you may not agree, but maybe we do have a workshop just on a claim. Why, what, and how. That might be helpful.
And Robert, if I could inject something there, and I think Warren's points are right on. I think it's very hard when you see $12 million. Like you say, Warren, we immediately pull out of the air $5 million. Well, that $5 million was based on a lot of assumptions. Sure. And I remember when Sharon made her presentation at Commissioner's Court, we were there, and she made the comment, these are based on a lot of assumptions, give us a 1 year, true operating result. Now, it's $12 million. Is it going to be 18 next year and 24 the next? I think you're right. I don't think it is, but I think we need to start comparing apples to apples, because we're kind of comparing an assumption, and we said, give us a 1 year. I'd love for it to have been 5. It's 12. I think the other issue that I'm not taking exception with, you keep hearing, and I do too, oh, by the way, some of that $12 million used to be paid for over here in the district. Well, what were they? And I think an acclaim type off-site budget would be very good, Robert, to delve into that. I think the word maybe is not there was 12 or 10 million over the losses that the hospital was carrying for the JPS physician group. I'm not saying that. I think the word is allocated expenses. I don't think we're on apples to apples. I don't know exactly how much of those expenses that Robert's making reference to that the hospital used to pay for JPS. I don't have those numbers, and I think in an off-site discussion or whatever, we could get those numbers. I truly agree with what you're saying. It's hard to compare an assumption that we're only going to lose $5 million last year, and a lot of things happened during that transfer over, and then now that we got it, then that's where we are. And again, I talked to Ralph. Ralph, by the bylaws, the vice chair serves as chair of the acclaim executive committee, and Ralph was on that committee last year too. And there was this time to move and get this thing set up. It's set up now. We ought to be able to start seeing year-over-year comparisons, which I think it's kind of hard right now to see. That's just my personal opinion.
The only thing I would ask, and I know that y'all will do this, is, again, to strip the politics of everything when you have a monumental change and deal with the realities of what we have with it. And I would totally agree. So none of my comments were meant in any other way other than say, let's go back and look at what we have and why we have it. But that doesn't change the attitude that you may or may not have towards the budget. You do as you see fit in whatever way. And I think that will be fine. But
to me, a claim and the budget, those are overlapping issues, certainly.
Exactly.
But they're not the same.
I understand. I just appreciate it.
May I add a quick comment on this page? I see where we're going from the financial standpoint, but my struggle is that I don't know a line of service, and it's kind of hard to see where it's trending. I just don't see the line of service that we provide, and and on top of that, overlay that with the population that we serve, because I don't know if the district is the right number, how much it's going to affect us if our population on the indigent care and the underserved community goes up or down. We register people, but how many of them are active patients? And then are they all really sick? Are they all healthy people? And all that stuff, because that will dictate how do we recruit people, and do we know enough to see, because I'm trying to compare statistics with different facilities, right? And with what insurance paying for. And when I look at, like, when you bundle supply and prescription, I can't say is it high or low, because the drug side is now approaching 30% of healthcare spend. But I can't say, are we kind of in line or not in line with what norm? And then on top of that, with our population, should they, because of lack of adherence to or compliance, then is that going to be higher for us? And how's that going to affect going forward? Are we taking like if you look at the DISH RIP and the DISH number and uncompensated care, are we account for the dollar amount that this new administration going to impose on us, right? Because that $43 billion that's going to hit us in the next few years, we'll start out with 2018 with $2 billion. And Texas is 6.7% of that $2 billion cut. And we are 14.73%. If I use that 151 number, we are 14.73% of that total budget. So that reduction may hit us somewhere $1, or it could be $19 million. So I can't tell where we are. So if you can help us get through that, then I can say that 1% is safety net, safety for us. Or is that 1%, is that the right number for us to look at from the operating expense type thing? So those are just curious, that because I don't see the numbers, so I can't flip them.
Well, if you have any specific questions, I mean, it's difficult to know exactly what level of detail to present at the board level. So when you have specific questions, I'll be happy to get with you and drill down into that level of detail with you, DT, at any point in time.
So are we taking any consideration of the impact on that DISH number, the 151 million?
So when we get to there is a reduction of DISH that's planned, and there's a couple of slides in there for the supplemental funding. Right. And we'll see if I answer your questions on that. Okay. We do plan for the 15% reduction of DISH. That may or may not answer your question. We'll see when we get there. Okay.
Right.
All right.
Sharon, I'm going to go ahead and set up a meeting to talk about a claim for why it was generated, where it is, et cetera, et cetera.
Okay.
It'd be helpful. I think that'd be great idea.
And we just got the first pass of the financial stuff at the last meeting. It's really part of the routine agenda. One of the things that I would like to see is service line income and expense. We don't have that as of yet. And I'm pretty sure that Dr. Johnson at some point, and hopefully soon, would be able to look at each practitioner with the RVUs, and income and expense, to evaluate the group at that level. Because I think you have to have that to be a functioning entity.
It's always tough going through budget. I mean, you pull your wish list together.
Sure.
I'm just trying to get a view of strategic rather than versus day to day, because it's going to float. And
I understand.
We have to manage.
I understand.
Have to manage that.
Okay. So let me go through the next slides pretty quickly. I put the destination metrics in here just to remind you that the budget is not all about the numbers on the Excel file. We have 9 overarching destination metrics that you have approved. These are the current ones, and I tried to pull out a few, with the help of my colleagues behind me, things that are in their budgets. I asked them to list 2 to 3 main goals that are in their operating budgets for the year, and you can read through these, but these are the 8 destination metrics that are embedded in our budget that we are requesting approval for today. The 9th is a positive operating margin. Some of the additional strategic initiatives, as we talk about capital, will be design and development dollars for our ambulatory surgery center here on the main campus, the cancer center, which was also included in the prior year, and a psychiatric emergency department as we outgrow the current one that is in the tower. The completion of our Northeast Medical Home will occur in December of 18. We are also currently looking to collaborate for additional respite beds in our community. Community health clinics, looking to see what changes we can make there, and public-private ventures. So everything, if you remember from a year ago, when we talk about what drives our budget, it's volumes. So you look at our key inpatient statistics, our admissions, we are going to see about a 3% increase there, and our patient days follow that. We've talked about T9, and that will, the full year impact of that, along with the recruitment of the new urologist that will start the end of this year. ED and urgent care are just about at capacity this year, so we're not expecting much of an increase there.
Sharon, just for your numbers, can you back up just one
I
second?
can.
It's on the emergency department visits. I believe that we're already at 115 to 116,000.
We are, and thank you for pointing that out. So we have, there's a little note at the bottom of that slide. These numbers have been restated to a different method of counting. So if you look at the way that we're counting now, our projected number is going to be probably about 130,000 visits for this year. If you convert it to the new methodology, we'll end up at about 115,000 visits. Under our current, we are counting a few things other than just what we call E&M codes, which is when you drop a charge for just seeing a patient. We do some other things in the ED that if you go out and, again, from an industry standard, if you want to be comparable to every other hospitals, you can count other things in the ED. So if we go to the new standard, we've gone back and we've restated 16, 17, and 18 to use that new methodology. So what we're showing here for ED visits is apples to apples using the new method. So it doesn't impact revenue, it doesn't impact anything except for just the count. Does that make sense?
Well, I guess from my own education, you're going to have to walk me through what the standard new stuff is.
I mean, we don't have to do it right now, but
Okay.
it's new to me. I don't,
Well, it's new to all of us, and if you're going to hear it, I'd like to hear it, so.
So, a few years ago, when we looked at the way the ED counted, sometimes they would count left without being seen. So we had to change the way that happened. currently, if they go in and they touch a patient record, it created a count. And so there is a potential for a double count to happen in the current methodology. And so for FY17, we would potentially show 130. And it's not always a double count, but it may not be a new patient record showing 130. So an E&M code is an evaluation and management code, and there's 5 levels that can be generated in the emergency department. So a level 1, 2, 3, 4, and 5. I know you know this, but everybody in the room may not understand it. So beginning in 18, the standard method in which we count an ED visit will become, you get 1 count for level 1, 2, 3, 4, or 5. And if you go back for 17, instead of about 130, we would have 115. So we went back and recounted 16, and that would be 113,000 visits. So again, it doesn't really change anything but the count. We're not going back and restating revenue. We're not going back and restating anything. It's just going to be a different way to count the emergency department. And this is the way that we're going to show it in the future when we show it to you for the emergency department count. It becomes more important the way that we count certain key statistics as we start to implement productivity, as we start to implement cost accounting, and as we start to compare ourselves against industry standards. So as my department and my folks start to peel apart how we've reported things to you in the past, we may start to say, you know, we're going to start to report to you a little bit differently than we've reported to you in the past. It does not mean that it was wrong or it's incorrect. It's just going to be, this is the way that we need to start to report it to you now, and that will make it comparable to the way that we show it to you compared to our peers in the future.
On the 18 for the ED department, at what point do we hit capacity issue that we have to deal with diversion to other hospital? Do we know, or do we plan for that, or?
What was other hospital?
At what point
We
do
hit
we hit
capacity.
capacity and we go to diversion?
We don't.
We don't go to
We don't
diversion.
get to go to diversion.
You're not going to go to diversion here.
Actually, they're diverting to us.
Yes, we do not divert. Where our challenge lies is when we hit capacity, and Dr. Schrader is in the audience, and he can say this, and others can say this, and if Wanda were here, she'd say the same thing as well as Bill Whitman. Our challenge is when we get to that point, it compounds our boarding issue, but we handle everything that we can handle in that ED. We do not have a diversion policy. So we look, we wait, we fight, we do whatever we can. And I would boldly stand up for our ED nurses and our ED staff. This is a no divert facility.
I would agree, and it's tough. It's tough.
It's tough.
At times. And we do not divert. We don't turn anybody away for that type of thing.
Okay.
Thank you. So we just look forward to new numbers.
Capacity.
Yes,
Reprogram.
Yes, sir.
sorry.
Yes, sir.
Okay.
Surgery, again, no substantial changes there, except for the 200 cases that we expect from urology inpatient. Our outpatient statistics, these again are our community health. And I did want to mention here, 580,000 visits seem like just a whole lot to me. So about 310,000 of these are primary care. Another 182,000 are specialty clinics. Women's services account for about 50,000 of these, and our school-based are about 38,000, just FYI. Key behavioral, not a whole lot of change in patient days. We tend to stay very full there. Our psych emergency stays relatively flat, again, very full already. Clinic visits, we do expect about a 10,000 increase there due to scheduling and provider utilization changes, and partial days remain fairly flat. Our revenue sources graph stays pretty constant year to year. We have a little bit more revenue from patient collections than we do from our ad valorem tax revenue, about 40-40. Our UC, DSRIP, and other supplemental funding provides about 15%, and we get about another 5% from other revenue, our grants, our tobacco fund revenue, and other non-patient sources. Our payer mix remains relatively constant. I would like to point out last year our graph was about 12% commercial, and our Medicare mix has increased about 2%, mainly because of our contracts that we have been able to secure over the last 2 years. So net patient revenue. This is one of the bigger changes in our presentation today. The biggest here is $12 million that we are going to be able to secure from Medicare DSH. Whoa. Thank you.
That was
From the control booth.
That was a statement, don't cut their budget. That's all that was.
Wow. So our CMS update, and just to remind you guys, Medicare is a federally run program. So they pay us every time we get a payment, a DRG payment. They give us our DSH and UC payment. Medicaid, on the other hand, is a state-run program. And because of lots of different reasons, we get those payments once or twice a year in supplemental funding, and it is very complex how we get those payments, and we're going to talk about those in a minute. But this DSH and UC comes from Medicare. And CMS reallocated $2 billion next year for Medicare DSH and UC. And then on top of that, they decided that they were going to change the way that they paid and distributed the pool. They went from going simply from number of days, which they had in the past, to, hey, we're going to look to see how much that day cost you. And so we won on that redistribution. They looked at our cost report instead of just saying, okay, you provided X number of days amongst all your peers. So we're going to pick up an estimated $12 million next year because of that change. Because of some of the volume increases that you can see, we're going to have about an $8 million pickup in net revenue. We also estimate about a $7.6 million increase, and I'm going to talk about that on the next slide, from revenue cycle and some of our case management initiatives. And our charge price increase of $4 million, that is collected from our managed care contracts. We increase our charges. They expect us to do that. We're limited to 5% a year. And again, that comes not from Medicare, Medicaid, and obviously not any self-pay, but really just from our managed care contracts themselves. So that generated $4 million. So splitting apart revenue cycle and the case management initiatives, there are two very focused rev cycle issues that we're looking at this year. There's the pre-auth process in surgery and oncology, and we're also going to do a house-wide timely charge entry and charge capture that we feel like is going to be able to pick up and reduce some denials. Also, you approved last month a new eligibility software that we feel like is going to really improve some accuracy on the front end. From a case management standpoint, we are going to pick up by adding 17 FTEs, which is a significant initiative. The biggest focus is going to be on the ER side and criteria for admission. And you can read through all of those check marks there. And Dorothy, hopefully this is going to answer a lot of your questions, but it's going to allow Wanda and her team 24/7 coverage, which we do not have right now, to review all the criteria for admission, decrease length of stay, the inpatient, versus the observation questions, correct status, all of those issues that we are really focusing on. And from a budgetary standpoint, what I budgeted for was actually only the pickup that we have on decrease in denials, not really the savings that we would have from decrease in utilization of resources. So I'm feeling that this is pretty conservative. And then the second bullet under that is really for scheduled admissions and pre-admissions. And there's 4 FTEs segmented on that, and that's just 100% of review on all admissions. And that's pre-auths and admission status for procedures.
What percentage review do we do right now?
We do what we can, and they try to hit the high dollar accounts. I'm not exactly sure what pre-auth we are able to cover. So.
How many people are involved in it right now?
I think there are 2 FTEs right now. So 4 FTEs would allow us to do 100%. So you can't really say that we're only doing, like 20% because we do the high dollar. So
the
it's
dollars involved,
yeah.
probably the majority. But
Yeah.
So you want to triple the number of people that are working.
Correct.
Is that the same as pre-access, or is it in addition to pre-access?
Say again, DT.
Oh, it's just asking to see if this in addition to pre-access, or is it pre-access type of people?
I'm not sure what your definition
To
of
call ahead for
pre-access.
schedule, to get authorization, to get all the...
Well, these are actually nurses,
Okay.
and it's not registration folks. This is actually case management. Yeah. So this brings us to the other segment, the other 40% of our revenue. So this is our ad valorem taxes, our 18 budget, $383 million. This is about a 10% increase. And I think you guys are familiar with this slide. This slide is actually something that requires a separate approval from the board, a recommendation from the board. I will not read that to you.
We have to do that today.
We're going to require like an effective rate notice and those kind of things. Cities are. We're going to talk about that. Oh, we are? Yeah. Okay. Golly gee, I look forward to it. Now I'm leery.
Are you weary too?
And teary-eyed.
Our other operating revenue, which is our UC, dish, and disrev. Uncompensated, yes.
I wanted to put the slide back. Is that tax base 154 billion? Is that what that says?
It is in billions with a B. The 170.4 billion. Yes, sir.
Thank you.
Yes, Tarrant County. The other operating revenue, we have UC, which we do not really expect any changes this year from 17 to 18. There's a slight change in the FMAP. Our dish, Dorothy, was it you that was asking?
DT.
Oh, I'm sorry, DT. We are expecting a 15% decrease in federal funding to the state for DISH. That's going to cost us about $4.5 million. In addition, we do have a slight decrease in our Medicaid days, which is another $1.5 million. So I budgeted a $6 million decrease in our disproportionate share funds from Medicaid.
We have always a challenge with this because if you all know, particularly those of you who've been on the board for the last 5 years, the issue of DISH going away or 1115 waiver funds going away is always a topic of discussion. We're never quite sure what we have and what we don't have. We have been fairly constant for those years that there's always the possibility that it will go away. I know the state of Texas is fighting hard for the 1115 waiver and the disproportionate share dollars and others that go with it. Whether you like it or don't like it is not the issue right now. It's whether that money will or will not be there. And we're going to make the best predictions we can. You cannot just listen to the fact that it's all going away and that you have to be also sensitive to that. So we try very hard to be realistic with you all and the citizens about that dollar amount.
Go ahead, Ralph.
Yeah, because my concern is that we don't know which way it's going to go, but there are some key programs funded by those dollars. And if the dollars shrink or go away, what do we do in picking up those programs?
Well, I think what we would do is if by chance, and we face the same issue actually if it increases, and that is where do you go with those increases and how do you analyze that?
I have a spot for you, but go ahead.
And I think what we do is if there are significant decreases or significant increases, we would go through an analytical nature that had the greatest impact to our patient base, and we would not only share that with y'all, but we go through that all the time right now. Which ones are effective, which ones are not. That's why we adjust our 1115 waiver projects for the ones that are the most effective for us and reap the most dividends. We've had 1115 waiver projects that 4 years ago looked really positive and we thought would have major impact that didn't have as much impact. We'd had some that we thought, well, let's give this a try, and it worked exceptionally well. So if we get a reduction from the federal government, we would look at how to best deal with that like you would any other cut. But you can't make those cuts in light of what we think might be a rumor, and you can't add thinking that, well, we know they're going to add, because we know they're probably not going to add, but we don't know the effects of anything in the next year.
And Sharon, correct me, last year after we went through the processes and the budgeting, we found out 1 month out, based upon a state making a decision on percentages, that we lost $10 million.
Well, the 10 million, the 10 million.
That's
Here we
all right.
go. That's okay.
Cash
It's all right.
is cash.
The 10 million was not from a federal decision being made. We budgeted for the legislative decrease and the big dollars going down.
Right.
What our 10 million came from was once you get to the state, there's two other stair steps that happen. And I don't know if Mike's back there, but he's probably going to go.
No, go ahead. He's gone.
He's gone. Yes.
Good.
Yeah, the flash-
Pressure's off.
Yeah, the
Nobody
flash-
else
yes,
knows.
yeah.
Nobody else back there can correct me. All right, so,
We didn't get it, I guess is the
all right,
point I'm
that's
saying.
okay.
You don't have to.
So there's 5 pools. One of them is the large public pool. So that pool happened to go down based on everybody's costs. So that we weren't expecting. And then once we got to the large public pie, our relative costs were smaller. Everybody else's went up, and so our piece of the pie got smaller unexpectedly. And you don't know that until the end of the day, the end of the year. And so that is what happened. It wasn't that the pie got cut. What's happening here is the feds are actually decreasing the full dollars that are getting allocated. So step one, they're saying we're cutting the funding by 15%. So we're able to budget a 15% decline. We know that's happening. So that's where that $4.5 million is coming down. So that's a little different than our pie is shrinking. We know that the entire budget is going down. On DISRIP, we talked a little bit about that on the first slide, so there's really no reason for, unless someone has a question, I'm not going to cover that again. And other non-patient revenue is mainly grants. We're seeing a pickup in that, but I do want to point out that a big part of that is our pharmaceutical assistance program, our PAP drugs, and you're going to see an offsetting expense when we get to medical supplies, so that's kind of a wash on our bottom line for the most part. Also, what goes into here is our tobacco fund revenue. We have talked about that we got a nice pickup this year for tobacco fund revenue. We are expecting about $1.8 million less in 18 than we got in 17 because the state had thrown some discretionary monies in 17. They have told us that they will not be doing that in 18. So on to operating expenses, unless there's any questions on revenue. I'm getting the signal. Total comp. In salaries and wages, we have budgeted for merits, incentives, and our filling of vacant positions. We're going to be talking about FTEs on the next slide. We do have 2 cost-saving ideas. We are focusing on overtime reduction. We're going to be bringing that down from about 4% this year to 2% next year. We've already started that, so that's not a hope. That is something that we're already doing. So that's going to save us $2 million next year. We also talked about the productivity implementation. That's going to save about $2.6 million. That is a multi-year program. You're going to see about a $1.3 million expense in purchase service to bring on that program. On benefits, we do expect to see some savings there after an unusually high experience in 17. And we will begin trying to migrate employees from the Richer Select program to our Choice program with a focus on some wellness initiatives. Also, as a claim brings on more employees. They pay us for their health insurance, and there's an acclaim benefit credit that comes in and offsets that health insurance. We do have an increased tax expense on increased salaries, and we have continuing education for Pathways to Excellence for our nursing program. So FTEs.
Is the,
Pardon?
on the total compensation is, oh, I see it, I'm sorry, I was looking for the incentive program, okay, I missed it.
Are you good? Okay. On FTEs, our FTEs per APD, you see that, I'll use my little board here. We budgeted in 17, 5.96. We are currently at about 5.86. And our 18 budget would propose a 5.97 FTE per adjusted patient day. We would be increasing a net. If you look at these two numbers, we would be going from about 5,600 FTEs to about 5,611, or about a 12 FTE increase. And our benefits percentage, again, we've had an unusually high year in 17. And that would bring us to professional fees. Professional fees are those that we, for the most part, that's what we pay to physicians. A large part of this is professional fees that go through our connection program, medical directors, GME, coverage expense. We have about 11.6 million increase. I'm going to hit the high points of those, and if you have any questions, please let me know. Hopefully a lot of these you've already heard about in prior committee meetings. Two of the largest things we've talked about in relationship to a claim. There is a compensation plan that is going to be implemented next year. About half of that is going to be rolling through our coverage agreement. There's about a $20 million coverage agreement for our academic and administrative roles. So about 2.3 million of those increased salaries are going to be picked up by the medical center. There's also 2.2 million of benefits that have never been charged appropriately in prior years that relate to that same professional services agreement. So that is a new charge, although it's not a new agreement. That is just right-sizing that agreement. The neurology services, that came through the Finance Committee probably about 3 months ago. That is additional coverage at a cost of just under $1 million. The next item, there are staff salaries of about $900,000 that were formerly in our salary line item that were transferred into a claim that are now going through these professional fees. So it's not a new expense, it's just in a new line item for this budget. We also have incentive payments that are now in quality metrics instead of kind of a base pay for these physicians. We also have full year impacts of admin hours. We have the transition of the surgical services coverage. We also have new roles for inpatient and ambulatory directorships. The urology services, which is new for this year. Administrative costs for coverage fees in ophthalmology. And the last one is, again, just a transfer to a claim. So it's new to this line item, but not a new expense for optometry services that are transferred to a claim.
Sharon, before you go from that page.
Yes, ma'am.
On the full year impact roll transfer to a claim, formerly included in JPS salary. So JPS salaries went down or no, we had FTEs. Did the FTE count go down and the money was transferred? Is that?
Yes. Yes, the FTE count would have gone down. And so now a claim are carrying those FTEs, and we are transferring dollars in this professional fee line item to fund those.
Okay, all right.
And some of those might be for the trauma team. It could also be for the homeless care team. Those are two of the larger groups.
Okay.
The other line item under professional fees relates to our IGT expense. And you can see the 5 largest offloaded contracts. These are the 5 total, but there's pretty large contracts. We do see some increases here. Because these are offloaded contracts, we budget the quality and the admin at their full rate. So you see those increases there. And the other line items are legal, audit, and consulting fees. And the increase in consulting is the $1.4 million for the productivity study, which has the $2.6 million savings in the salary line item. So, purchase service. When you look at purchase service, these are our outsourced items. These include, the biggest cost in purchase service is our software, which is our EMR, housekeeping, collection fees, and minor equipment. So some of the biggest full year impacts here is our pharmaceutical agreement, our blood bank, again, outside medical services, the software licenses, IT infrastructure. You can kind of read down through there. We've also had a planned reduction to increase some of our pre-authorization and medical management. And if you have any questions on those specific ones, I think those are pretty self-explanatory. If you,
I'm going to come back and ask I see that a lot of this has been offset by employees.
yes, ma'am.
But I didn't see a decrease in FTEs. So is this FTEs went up. So, but we keep saying we have an offset of employees.
Mm-hmm.
The cost is being offset by a reduction in FTEs. So maybe I'm missing it, but how many FTEs have we reduced? Because I don't see that when I look at the number of FTEs we're budgeting.
Right. Well, if you remember, we just had a net increase of about 12 FTEs, and we added almost 20 in case management from our revenue slide.
Okay.
And in a minute, you'll see that we insource some things to save some money and some other categories. So we added some in some other areas, like in maintenance and textile. We added a new MRI So there were 3 there, and you may not see all of these in the explanation. So there were some adds, and then there were some reductions. And I can share these with you. But there were 5 reduced in pharmacy, the blood bank, that pro forma, and I believe we reduced 10 there. So it's just, we added some in some areas, we reduced some in some areas, and then that netted down to the 12 net additions.
Okay.
Are those, were all those filled positions or were it just positions that were vacant?
Were which ones
When
filled?
elimination, when you eliminate some.
I don't know that.
And I'm sorry, I shouldn't be asking you that, but I guess I just,
Well, like the Carter Blood Care, that was done, these were items that were done during fiscal year 17. So those were done, I don't remember which month, but earlier this year. So those are things that have been in place for a while.
okay.
Did anybody have any other questions on purchase service? Okay.
It's just a statement,
Sorry.
but under the last one, you're going to reduce the medical service reimbursement with improved pre-authorization and medical management for the unfunded patients. So you are reducing staff to look at that? Is that what I'm
No, we're actually, there, medical services reimbursement, we do, there's kind of 2 tracks. There's one for connection patients, and there's one for self-pay patients. And for connection patients, we have a pretty robust pre-approval process for outpatient services, like for MRIs, for other kind of high-cost medical procedures. For self-pay patients, that process is not as robust. And what we're going to do is we're going to add 2 FTEs to make sure that the process is identical for all patients that we pay medical services reimbursement for.
okay? Thanks.
It's very similar to what we're doing on the top side. This
Right.
is just,
Yeah, I just didn't understand what it meant, so that helps.
so under medical supplies. Oop. Okay. Under medical supplies, we have a 7% increase. We, mainly due to the fact that our inflation factor for drugs and pharmacy is 12%. Not only is that our historical experience, but that is our industry standard. So, that is, typically our inflationary impact is about 3% for all other categories except for pharmacy. So, I just wanted to point that out. That is we do have some increase related to higher patient days, but it's mainly the 12%. And then our other expenses, it has increased 10%, but I think rather than just go through each and every one of these, I do want to talk about, we tried so hard to hold a lot of expenses during fiscal year 17 because of the unfortunate loss of UC dollars that we had early on in the year, and we knew it. As you read through some of the recliners in behavioral health, the linen restock, a lot of these were things that we just held on in 17, and we did have to go ahead and do in 18. So that was the reason for the larger variance in 18.
Sharon, on the pharmaceutical spend, how much are we, do we have an estimate, how much are we throwing away, expired drugs and all that stuff? And are we making progress in that area?
I would have to get with our pharmacy management. I don't know exactly what our expired drugs would be. But I can get you that number. Depreciation, we're budgeting about a $45 million capital spend for next year. We'll cover that under the next section. And our non-operating revenue, based on the market trend, we are hoping to get one bump in our earning rate, and we do have about $675 million invested right now. So that's going to spin off about another $1.8 million next year. So for our income statement for the network, when you add all of that together again, our margin is $23.2 million, or 2.4%. Bottom line of $33.7 million. Again, the target of 2.4% came from the overall combined of 1%.
Okay.
Any questions before we go into capital?
Just curiosity.
Again, DT.
Just for curiosity, how much would it cost us if we were going through the bond per year in principal and interest? Is any?
You know, the interest, the question was how much would it cost for principal and interest with the upcoming bond, if we were lucky enough to be proposed with one. You know, just the interest component would be probably about $24 million. I'm not sure what the principal payment would be. It would kind of depend on the structure that we worked out. I don't have that information here with me today.
In a couple slides, you're going to talk about the JPS Future Fund. Shouldn't I, where is that? Is that on this slide somewhere in one of these numbers?
No, the future fund would not impact any reallocation of operating cash, would not be an operating expense. It would just be a reallocation of excess funds on the balance sheet.
The JPS
Future
Future
Fund.
Fund. I mean, we'll get there in a minute, but so what you're saying here is at the end of 2017, if we have money left over, we're gonna put $5 million to the fund, but we haven't done that yet.
Correct.
And in 2016, we did, but it's not reflected on anywhere on this number.
Correct. So I'm gonna go accounting on you for a minute.
Sure. I'm ready.
So, are you ready?
I'm gonna steal myself.
This is gonna be really exciting.
Go get some fries.
All right, so this 14.7 million at the end of 17 will go into retained earnings.
Right.
And it'll live on my balance sheet. And the 5 million that we're talking about that's going to go into the future fund will go from one balance sheet account, an unrestricted cash,
Right.
to a board designated cash account. So it's just going to go from one cash account to another cash account.
just-
It does not impact anything on my income statement from here on out.
Okay,
that
so if I were to, and I know that you got your slides in your order, and I'm messing with them a little bit. If I were to look at the JPS world and all of its funds, There is a fund somewhere else, it's not on this sheet, that has $111 million in it.
On my balance sheet.
But where is it really? We have a bank account that has it money, right?
We do.
And
I don't have a balance sheet that, well, I might. Do you have the, does somebody over there have the board? Do we have a balance sheet clearing?
Please don't make your girl a lawyer.
Okay, no, I'm not, I just want to make sure that, I like money.
If we have a balance sheet, I can show you where
Okay.
those live.
All right, so it just kind of
But
lives
if
in our.
not, I can pull it up in a little
It's
bit.
basically money you consider yourself not being able to spend, and it's not part of our expenses.
It would be, so the bigger unrestricted is on my first line of my balance sheet. And the 111 is on kind of a few line items down on what we call a restricted cash. So it's just earmarked. It doesn't, and it's all commingled in one happy fund at the bank. The bank doesn't know that.
Right.
Yeah, it all
My
lives
bank
happily
account
together.
knows I pay money to this bank over here every month, same amount, but it doesn't know that. It has to. Yeah, it's true too, but I'm not talking about
Yes.
that. Thank you.
You're welcome. Okay. So our capital, and again, this looks so easy and it is not. So our capital, we start with, what is our depreciation for 17? So from my standpoint, we want to reinvest in our property, plant, and equipment what effectively has depreciated, and that was $38.7 million. We had allocated last year $1.5 million for cancer center design that we did not spend, so I'm proposing that we just carry that forward. We also did not spend $3.8 million and $1.5 million for strategy and facilities. So that's another 5.3, and I'm going to talk to you about that in just a second. So that's 45.5 million. After all is said and done, with all of my friends behind me, we have lists. They're not. If they'll time heals all, right? 17.7 million for equipment, 8.5 for IT, 9.6 for facilities. We set aside $4 million for strategy because we don't know what will come down the road, either from a physician needs standpoint. We don't know what the board may determine is important for next year. We set aside $500,000 that may not be on the lists above from the operation group. And I'm going to ask that you allow us to carry that $5.3 million forward to build out one of the 3 items that we have on the next page. Either the psych, ED, the ambulatory surgery center, or the cancer center. Because I do feel like one of those 3 facilities will come to fruition, and we will need that 5.3. So instead of just plowing back that 5.3 into equipment or something else because we had it, I wanted to kind of set that aside and say we know that we need some additional construction dollars. So that was my thought process of saying, you know, we had it in strategy and facilities, so let's leave it in strategy and facilities and earmark that cash for those needs, and we'll just carry it forward.
Name those 3 again.
They're on the next page in your book under construction. We have asked for dollars for the psych emergency department design, the ambulatory surgery center design, and the cancer center design. Now, the 5.3 is not enough to actually build those, but it would certainly start to, it would be a start on any one of those.
Has it been identified on facility upgrades and renovations, or is that just general?
The facility upgrades and renovations, the biggest part of that is an elevator modernization in the main facility. If you
Don't talk about elevators, not at the board meeting. Whatever you do.
I know, it's not sexy, but that's what's in there for $1,000,005. So, you know, there's also some ED lab expansion, and yeah, that line item is not great for $1,000,005, but it's very much needed.
I asked this question some time ago, and maybe you can explain to me again. It might have been Kathleen or Bill I might have asked this for. On purchase of capital equipment, do we build in any type of replacement cost each year as that equipment ages, that we set aside dollars someplace so that when it's time to replace, the dollars are there as opposed to?
No, not specifically, because each year I fund depreciation. So, you know, if your depreciation costs are $40 million each year, and you're allowing a $40 million capital budget, you're effectively funding your depreciation each year. So, you know, if you can really get yourself in trouble if you're restricting yourself to a $10 million capital budget and you're depreciating $40 million. You know, then your capital, your plant and your facilities and your equipment are really degrading. But we've not done that. Other things that are in here in radiology, in the line item radiology, we have in the $1,000,004, there's really not one big thing. We have, there's some construction for some radiology items on the next page. Nursing unit renovations, we're going to focus on Tower 10 and Tower 5. And that's really the only things in the construction slide. On page 38, the hospital-wide IV pump replacement, that is literally IV pumps throughout the hospital. You have to buy them all, and you have to replace them all at one time. Radiology equipment, that does include a CT replacement in the ED. And the operating room equipment, there is nothing over $350,000. That is just a lot of different items. The endoscopy equipment, that is a full replacement for the endo suite. The nursing and lab equipment, the largest item there is replacing a nurse call system for about $577,000. The rest of them are very small. And in community health, that does include a linear accelerator at the cancer center. And then under IT, that is things that I do not understand. They do not want me to understand that. Yes, yes. $4.4 million for data center storage. Hardware and software includes things like Epic, Lawson, biometric patient screening. I had to say that out loud for Melinda. And then the virtual desktop infrastructure is phase 2 of a 3-year project. Any questions on capital? And then the JPS Future Fund. If you guys remember, we actually repurposed some board-designated funds from last year. We had $91.5 million from a depreciation fund, and we had $19.8 million from a renovation fund. I'm proposing that we add an additional $5 million of unrestricted cash into the future fund this year. The original proposal was to, from my standpoint, was to add any excess operating margin from budget. Well, if you recall, we didn't really have any excess operating margin from budget. We just met budget last year. But I do feel like, at least from my standpoint, we could put an additional $5 million into the future fund. So that would be up for a vote at the end if you saw fit. Any questions?
And that $5 million going to the unrestricted one?
It would be going from unrestricted cash into a board-designated fund, the JPS Future Fund.
Thank you.
Do we take the 5 at the end of this fiscal year?
Correct. Correct.
I was just asking, we'll take that 5 million out of, at the end of this fiscal year.
Mhm.
Sharon, I got a question on the capital projects. At what point do we say, let's wait and figure out this bond thing before we spend X amount of dollars on something in this building that might be part of that bond fund anyway? I mean, does that make sense? I mean, I realize the construction, if the bond passed, wouldn't start tomorrow, and we're probably looking 4 or 5 years down the road. I get that. It seems like it would be better if staff prioritized those construction projects based on the potential of that bond issue, and we funded that at this time, and then if the bond didn't pass, then figure out a way to make up the difference.
So we are very careful in our planning process to make sure that either on these planning and facility, or, for new facilities like the psych, the ambulatory, or the cancer center, that those would not be in conflict at all or would be complementary to the master facility project. And anytime, like with the nurse call system, we make sure that we are putting those dollars into the pavilion and that we are only extending the life of the tower. So anytime that we're talking about a renovation for the towers, we're only doing the minimum requirement. So we're really very careful about what dollars that we're putting into the current building. Also remember, even if we were at the point of a vote, before and breaking ground, it would probably be a good 4 years before we would vacate the structure, if we were to completely vacate the structure. So you're still talking about, you've got 4 years. That's me talking, not any expert.
No, I understand.
I am on camera. That's just my guess. So you do still have to maintain at a certain level. So, but that is always the topic of this, always, yes, yeah. All right. Continue on. Okay, that was a little longer than an hour. So for a claim, And I think we've talked a lot already about some of the expenses within a claim. But a claim is going to be onboarding 41 providers. That's going to account for about a 15% growth in encounters. We've talked about the major contracts that are going to be assigned. Those are neuro, urology, and surgical services. That accounts for about $11 million, those 3 contracts. They also are getting a new district metric. They did have pain management. Now they are going to cancer screening, which works much better in a primary care setting. Because of their achievement of this, they're able to pick up $2 million. And that's new revenue for the consolidated district budget. They are picking up 2 new behavioral health clinics for MHMR at Circle Drive and Lancaster Avenue. The new comp plan we talked about, that's going to be fully phased in by January of 18. They are going to, there's some budgeted savings for in-source of contract review with in-house legal counsel. There's a clinician effectiveness program to reduce burnout and improve physician wellness. And complementary to what the hospital is doing, there's also focus on revenue cycle improvements as well. So some of their key statistics here. Total providers currently budgeted for 17 is 390 providers. So providers as well as nurse practitioners. 314 are currently working. They're expecting to onboard 35 in the 4th quarter of 17 and another 41 in budget 18. So that will bring them to the total 390. And then we are transferring 4 optometrists from JPS. So that will get them to their total budget of 394. And then you can see how there's no change in clinic staff. 1 is transferring from HR under the Physician Services Department into JPS. And the executive admin is the 1 legal. The encounters are going up. I do want to point out under primary care, that is the biggest growth. Although encounters are going up by 15%, you can see the largest growth, almost 47,000, are happening in primary care, and that gets us to our metric of the 3rd next available new patient appointment. Net patient revenue, most of this again is the new providers. That first number, the 3.8, is all the replacement positions, the 35 in Q4, plus the 3.3 million, which is the 41 positions that we're hiring in budget 18. The focused clinical time and productivity, we talked about earlier, and we do have a collection rate improvement of about $500,000. New contracts, and really focusing on our CBO. Other operating revenue. This is kind of the other side of our physician expenses on the medical center, so unless you have specific questions, I'm not going to roll through the GME and professional service agreement. We already talked about surgery, neurosurgery, neurology, the $6.7 million. I've mentioned the district change in the metric. Again, that's $2 million because of achievement that we did not have last year. and the quality incentive.
Question.
Yes, sir.
Okay, so here's the optometry transferring from JPS to claim 610,000. Is that going to be every year, or is that a one-time deal, or what is that?
No, so what happened is optometry used to be paid on the medical center. So this increase is due to the fact that they're changing from a medical center employee to an acclaim employee. So the medical center is going to be paying them to employ. So it's a zero impact on the acclaim bottom line.
Well, it's not is it a zero impact on us, or on the JPS bigger organization? I mean, I just see a bunch of dollars.
It would be a zero impact on the total organization.
Okay, so that in the
Yes.
wash, it's
It is a
zero.
wash on both.
Okay. On your pad, the numbers go here and there, but the bottom line stays the same, is that right?
It does.
That makes me happy.
It does.
Just the bottom line.
It's so complicated for everybody.
I'm a simple man.
On salaries and wages, again, we're increasing providers. There's a full year impact for these providers. And you have to pay benefits on all of these providers. We also have a full year impact for the staff to support those. If you have any questions on that, I'll be happy to answer them. On the physician remuneration side, again, the external groups, the surgery, neurosurgery, urology, to answer your question, Warren, we assigned these contracts. It's income to a claim and it is an expense to a claim. They are not employed, so those dollars flow in, they flow out. And then the UNT providers, most of the UNT providers are now and have become employees of a claim. For a while, to make sure that they stayed on as UNT employees to get their benefits. For the last few months, I think all but 3 now are going to be transitioning this year as acclaim employees. So this is... No, it really works out to be about the same after salary and benefits. Other operating expenses, there's really not any significant expenses here. This is where some of those dollars come to make the revenue cycle more efficient. Coding software, and this is where also houses the legal and consulting fees. Nobody is making eye contact, so I'm just going to flip through those. I don't know. When y'all quit, I'm just scooching on through. I'll take it as a gift. So the claim income statement, you guys saw this at the beginning of the presentation. $12.3 million bottom line for the year. They did have 2 capital requests for a total of $45,000, both in women's health. Any questions on a claim? Yes, sir.
And it may not be the appropriate time to talk about it here, but I'm going to because we're talking about budget. It's my understanding that we're having a difficult time attracting doctors and being able to pay them market rates to bring them onto a claim. That's a problem not just here, but anywhere that is hiring a doctor right now.
Mm-hmm.
There's nothing in this budget that would address that and or make it, because problems with a claim end up causing backup problems within the hospital system and all the various departments because people can't get seen and served and whatever else. That would seem to be, it would seem to me now that this would be a time to talk about either recruitment dollars or whatever bonus is necessary to attract the doctors, to retain the doctors, so that we don't have a backlog throughout the system.
So there are dollars in this budget, and if I skipped over that too quickly, I apologize. We are implementing the compensation plan, and it's going to be fully implemented this year. There's approximately $5 million that is going to be layered on during the year, and it impacts the five main groups that are at the lowest percentile currently. So that is going to occur this year.
And we try to, we'll see how that goes. We will come back to this board at some point and say that was the sweet spot and that helped us a lot in recruiting, or we don't need to do it again, or we need to do it again. That was our best estimate to figure out how you move those lower percentiles in the rankings, because we were down in the teens in many of those categories. How do we adjust them in a proper way and get them more competitive than they are now? Our attempt is to see how that works. But to Sharon's point, we did add to that. We are trying to address it. You want to address it to the full extent? We thought that might be fairly unreasonable to go to that amount, so we went to what we thought might make the best movement at the best dollar figure.
Fair enough, thank you.
And you know, when I was speaking to Reverend Emerson's point, you know, Dr. Johnson will attest to this as well. One of the main focuses is retention. You know, so you're not having to recruit new physicians, but to make sure that people stay, you know, and you're not having to re-recruit, so. Okay, so I do want to quickly cover the foundation. We do look at the foundation. The foundation's board of directors has approved this budget. These items are set up by their board of directors, and y'all can read through these, but you know, I find it interesting to maintain the number of tours. They provided 1,350 tours in 16, and they're on track for over 1,000 year to date. So
And let me interrupt, and I apologize for interrupting, but Pastor Emerson, that's exactly what we talk about when you say, and rightfully so that you say, what information are we getting out about JPS? Where's our brochures? What's in the mail? What are we saying? We have found those tours to be one of the most effective tools that we can have. And I've seen people, in fact, we just toured a group from Rogers' constituency, and the reason I know that is because they brought your name up 3 times, and it was in a good way. Well, all 3 of them had the last name Fisher, but it was fine. It was fine.
They're doing their job. That's fine.
It's that grassroots effort that I promise you that 90% of those 1,300 people that came here last year have had good things. I went to the HEB Independent School District yesterday and gave a speech to their Plan Ops and Custodial Services Division. And the reason that they asked me to come is because the gentleman that heads that up, a bright guy named Josh, took a tour here of JPS and said, wow, if you can do that at JPS, tell us at HEB how we can instill that cultural change. So it doesn't always mean a brochure, although those are great, and I understand, but those tours have meant significant impact for us. I'm done, but it was good. Just an editorial comment on my part. Everybody's just silent. It's like, is he going to say something else? No. Well, we are running out of time.
to those tours.
Yeah,
I don't know.
I have no idea, but it's a good idea.
But anyway, the foundation does a significant amount of things for the hospital. This is a really neat graph, just from restricted funds. This is just a graph of those that are greater than $2,200 a year. over $500,000 of support. This offsets our operating budget. So this is funding in total is almost $600,000 a year. Again, there's three major functions from an accounting standpoint and how we divide up their income statement. There are 12 foundation employees that the medical center supports their cost. This is not just fundraising. The foundation also leads all the grant activities for the medical center. And we get almost $6 million worth of support from grants. So when you see the 12 foundation employees, Amanda and her team are not just talking about fundraising dollars. It is all the compliance work and all the grant applications that happen. So it is a significant amount of support to the operating budget that you just saw. And not all of that flows through the income statement. And again, the Connection Supplemental Program, where those Tarrant County residents that have high deductible insurance, and we can assist with deductibles and co-pays when they receive their care here in a JPS facility. That runs through. So the two items that, and the reason that you're seeing the JPS Foundation budget, and those expenses are already embedded in the hospital budget, are these two numbers. Oh no, it works so well. Let's see, there it is. This $1 million that helps fund those 12 staff and all of the related expenses, and the supplemental funding, which is a dollar-for-dollar offset of those deductibles and co-insurance for those that qualify for that, that funding. And here's another look year over year.
No, I'll let her finish.
Pardon me?
And I was gonna let you finish first.
Okay.
Oh, no, this is not a foundation question. This is to Chairman and Mr. Early. Are we at some point going to talk about that first line item on the operating income?
The McDonald's.
Sure.
I just don't want to say it publicly. That's right.
Wait till sure.
After, I will, I did a little texting as soon as we started. That line item represents 8.5% of the gross sales that they give back to the foundation.
That's in the lease.
Yes, that's part of the lease agreement. They do give back about $150,000 a year to the foundation. That's what that represents.
Well, it's not, my concern is not what comes in. I'm concerned is
Correct.
that position that we heard today and what's sweeping through the country. That whole position of the company being at JPS. That's what I was wondering.
I think part of the issue, and I don't want to get into a huge debate about what fast food one eats or does not eat, but I think a lot of the issue for JPS and for you as a board to begin to discuss is if we have, and I don't want to hinge everything to a bond package, but if you have a bond package and you have expansion, that brings a totally different light to things. If you don't have a bond package and you want to look at some additional capabilities, what was said is do we want to look at our own service line, and what do we want to pay for that service line from an in-house standpoint, or do we want to look at other alternatives? All those, I think, are very viable, debatable points, which we will continue to discuss and will discuss. The situation that at least we are out of is a 25-year agreement that preceded all of us that is no longer there, that we now have a much greater capability to be flexible with. So I think there's opportunities for us, and that's not a hedge. It's just to say, how best do we provide the best services to our employees and to our patients in an attempt to keep them healthy, but also allow them to be adults and make decisions as well. So I think we can discuss all that, but I think it's probably more appropriate when they get closer to their, when we're discussing their contract and what we want to do from a facility standpoint. I always think that a overall food court where you have many decisions is always the best idea. But we haven't been able to do that in the space we've got.
The question was more, will we consider it now should be
Yes.
Yeah, I just want to, yeah, my question is at some point, will the board take a board position on that issue as it pertains to its relationship in health?
Sure.
You know?
I defer to the chair, but
In view of what was said today, I think your question, answer your questions, yes, we will certainly consider that. And we'll also probably address what other alternatives, if any, would be available during that discussion. So, yes, that point's been made, right? We'll come back.
okay.
I'm done.
You're what?
I have a question going back to the first line. If you don't mind, please.
County, we're only proposing a less than 1% increase in overall county funding. I mean, it's a big number when you talk about the overall county, but the percent increase is very small. Total. I guess the tax rate that we're presenting to the county is 1/6% of what it was last year, correct? Hospital district's portion?
No, with this.
7.5%
Yeah, Sharon, Warren has brought some information he'd like to present during this discussion. I think it's ready to go up on the, do they know it's going up?
Okay, yeah, Scott is letting know, and we'll try to get that slide up. This will indicate to you the nimble nature of our team.
Well, that don't help me none. I gotta get some new glasses.
This was given to the county commissioners this week, and then, except for the red part that I've added at the bottom. As Sharon noted earlier on one of the slides, the plan right now is a 10% increase in tax dollars from county entities and residents. For what we're doing, we adopted, or what we recommended already, and I forget when this vote was, but we recommended that we keep the tax rate the same. Of course, what everybody should recognize is we're raising taxes when we keep the tax rate the same, because generally speaking, appraisals have gone up. A lot of elected officials struggle with this concept, but I will tell you that just as when we were all kids, it was okay to drive when you've been drinking and blow smoke in front of infants' faces, at some point in the near future, whenever a politician or an office holder, appointed or elected, says, I didn't raise your taxes, I kept the same tax rate, everybody's going to laugh at you because you're demonstrating either deceptive intent or complete ignorance of how economics works. When we say we're going to recommend the same tax rate, we are recommending a tax hike. And that means, in real terms, if you had $100 that you paid last year, you're going to pay $107.70 some cents, just shy of $108. It's going up that much. We're raising taxes. Now, we just talked about a lot of needs and a lot of budget and a lot of things that people want to do. And what I don't want to do is say, I will never raise taxes under any circumstances, and if I discern in any way that I'm raising taxes, then I'm not going to do it. That's not the point of this discussion. What I want us to do is just be open and honest about it. My city voted not too long ago to tax itself, to give a billionaire a bunch of money to build a play place for other people. We voted for it. We raised taxes. If we want to raise taxes for a much more worthy endeavor, then we can do that. But let's not fool ourselves into saying we're not raising taxes, because we are. I don't think that the average person in Tarrant County got an 8% raise last year. And so if you want to go to the person who got a 2% raise or a 0% raise and say, we're going to raise your taxes by 8% so other people can have services, then you have to be able to say that. And I'm not sure that we say that the way we should. So if we want to go forward and say we're going to raise taxes by 8%, and we're going to do that openly, then that's fine. But don't be fooled. We're recommending a budget that spends 8% more of the tax dollar, that burdens the average taxpayer 8% more on existing property that they had, that's just normal property. And that doesn't count new property that's built up. We're just talking about average people, most of us in this room, and watching or whatever, 8%. And that's a big deal, and we ought to do that and think about that. It's easy as an organization that sits where we do to say we've got infinite needs. We can spend all the money. It doesn't matter how much we get, we could spend it. And we ought to be very careful about that, because there is another side. There are people that struggle to pay property taxes, and this is where you get it. That's all I wanted to say.
Warren, thank you for your comments. The way the budget, or the way the agenda is set up, we do have an item prior to making a decision on the budget, because I've been advised by General Counsel. It needs to be discussed and closed, and then we will come back and finish any other discussion relative to the budget. Prior to going to close, I think we need to back up to item 5A on the agenda. And Dan, I'm going to turn this back to you, if you wouldn't mind. It's to consider the approval of Brian Webb, MD, as chairman of the Department of Orthopedic Surgery.
The medical staff wants the approval of the nomination of Brian Webb as chairman of the Department of Orthopedic Surgery.
Have a motion, a second. All those in favor say aye. Opposed, no. Thank you very much. I know it's been lengthy to hear. Hopefully we will not be too long in closed. And at this particular point in time, at 4:25, we will reconvene in about 5-10 minutes in closed. Thank you very much. Thank y'all very much. We now will reconvene in open session at 5:35, and we will go back and we will consider item 8, A and D. The General Counsel advised me it can be voted on as one.
Yeah, the budget can be, the A, B, C, and D can be voted on collectively or individually. That's your call. Obviously, the Avalon tax rate has to be voted on separately.
Correct. If there's not any additional discussion, I'd entertain a motion on 8A through D. Have a motion by Mr. Montgomery, a second by Dr. Weber. All those in favor say aye. Aye. Opposed, no. In fact, let's do this on show of hands, I think it'd be easier for the minutes. Those who voted for, and those who voted against.
Mr. Chairman, let the record reflect that I choose to personally abstain from this vote.
Minutes will show that, so. Motion carried.
5-4.
Yes, correct. 5-4 and abstain. Is that correct? Is that the way you, minutes reflect that, Tammy? Thank you. Which brings us to item 8E. Oh. Which brings us to 8E, which is the setting of the ad valorem tax rate. Sharon, is there anything else you need to say at this time or anything? You're down on the agenda. Robert, anything you need to?
No. Need to specifically refer to in the motion the rate itself.
Which is on
the third line on page 20.
Okay. Then if there's no discussion there, I would entertain a motion on item 8E. 8E. Setting of the tax rate at?
Yeah, at .2278897.
I have a motion by Dr. Weber. I have a second by Mr. Montgomery. All those in favor say aye. Aye. Those opposed? Motion carries.
Mr. Chairman, I wish to be noted to abstain on this vote as well.
Dr. Lowry abstains, have the minutes so reflect. We only had one abstention. There was no no's, all abstain, just one abstention. Which brings us back to our privileges, and Dr. Siegel, I'll turn this over to you.
Thank you.
I'm sorry. I'm so sorry. I misheard. I was totally confused. Get down to on the tax rate.
Record reflect, after the vote taken, we so acknowledge.
Tax rate or the effective tax rate?
Get clarification, Neil, on the effective versus tax rate.
The tax rate.
Make sure we got the motion right on the
Motion
effective.
was to adopt the tax rate for the fiscal year 2018 budget at .227897.
Right.
Which is
I vote
no on that one.
No. No. I'm sorry.
Okay. I need to reopen.
Yeah, you need to call
For
for a show of
amended.
hands.
Yeah, I better have a show of hands, and we'll have the minutes reflect this final vote. All those in favor as 1, 2, 3, 4, 5, 6. And Roy, do you still abstain like you
Yes.
did in the previous?
Yes.
Have the minutes reflect that. Did we get the count right?
You get opposed.
Oh, all those opposed? We raised hand. 2, yes. Okay.
Thank you for helping us.
No, thank you very much. Clarifications is done. Now, Dr. Ziegler, back to you on privileges.
The medical staff is asking for approval from the board for the applicants for privileging.
Have a motion by Mr. Norrad, a second by Dr. Weber. All those in favor say aye. Aye. Opposed, no. Motion
Mr.
carries.
Chairman, I wish to go on the record as abstaining from this vote as well.
Dr. Lowry's abstained from that and have the minutes so reflect. Which now brings us, I do believe, to a conclusion of a very long afternoon. I appreciate all the time and energy. We've now been here 5 hours and 40 minutes. Appreciate everybody's time and attention. Is there anything needs to come before the board?
I want to say I quickly thank our first speaker today for using properly the word healthful. Healthful. It's a word.
All right. Point made by Mr. Norrad on that. There being no other business, we stand adjourned.